Hey.
Hey.
Okay, Dex. Annual exam time.
Anything you need, Doc. Bring it on.
So you're good with us drawing blood?
Yeah, I got more than I need.
A bone marrow sample? Because that could sting a little bit.
Yeah, pain don't hurt.
What's your feelings on amputation?
It's gotta go. It's gotta go.
And then, of course, prostate cancer screening.
Not happening.
Wait, you just said...
Try again.
Dax.
Listen, I'd rather do anything than get a prostate exam. I'd rather sit in the middle seat on a long haul. I'd rather watch 50 Shades of Grey with my mom. What is he putting on her? A choker? I'd rather sort my nephew's Legos by color.
Red.
I'd rather do hot yoga next to a sanitation worker.
Come straight from work?
Always. I'd rather be stuck at an ATM behind a guy on a speakerphone. Wait, what who say?
Jimmy!
Who?
Jimmy!
Oh, bro, eyes on your own paper. This guy's trying to jack my pen. I'd rather fold a fitted sheet.
Where's the corner?
Oh, here we go.
Yeah, wow, that's quite a list. Dax, 1 in 9 men develop prostate cancer, and do you know how we detect it?
Mean through the outdoor?
Yes, sometimes a digital rectal exam is necessary, but a prostate cancer screening starts with a simple blood test, which we are already doing today.
Well, why don't you say that?
Because this PSA wouldn't have been as funny.
Seriously, it's that easy. Go to pcf.org to learn more.
Hello and welcome to this special occasion. It's Prostate Cancer Symposium. It's a men's event, one that we've planned for a while. We've been looking forward to it. It came a little late. We had it, I think, the National Prostate Cancer Awareness Day sometime in September. But because of logistical planning, we decided we better have it today. And this is the very day that we are here to be able to participate in the event. I want to thank those of you who are here in person. But I know that we're just a very small representation of a huge audience that are actually watching virtually. And therefore, we're glad to be part and parcel of a huge movement of men who want to be aware of what, not just prostate cancer alone, but all other issues that pertain to men's health. And so I just want to welcome everybody who is here and those of you who are watching online. We are glad that you spared some time to be here today and become part of this movement. And today we're blessed actually to have a lot of guests with us today here, and we will be able to dedicate time when that moment comes so we can be able to enjoy the preparations and presentations that they have for us today. Just before we continue, I just want to specifically make sure that everybody is comfortable. We will be having sessions running between now and 6 o'clock. And therefore, we just want to say that those of you who are here, the bathrooms are out there. We have one on this side. Please feel welcome to seek for help. If you're visiting here for the first time, we are so glad to have you, and that most of our members here should be able to guide and lead you to whatever needs you have. So thank you so much for visiting. And again, it is Prostate Cancer Awareness Symposium. We will be able to address a lot of issues pertaining to men. We will have questions. As a matter of fact, I just want to make sure that you are all aware that in the course of presentations, if you have any question, you are free to type your question and send it to us, and we should be able to go ahead and pose the questions to the presenters at the very end of their sessions. And therefore, we have 4 sessions running. At the very end of every session, we have questions to be answered, and therefore be a part of that as well. Online audience, you are welcome to do the same. We will be able to receive your questions and forward them to the presenters when the Q&A session comes in. I just want to go ahead and ask Pastor to come in. This place, because of what we are doing today, has been recognized as a prostate cancer or men's health awareness location or event. And therefore, I want to invite Pastor to go ahead and preside over that session of the declaration from the mayor's office.
Thank you, Dr. Enos. My name is Christian Ronalds, and I would like to share with you the mayoral proclamation from the city of Hoover. Prostate Cancer Awareness Month in Hoover, October 2020. Whereas prostate cancer is the #1 cancer among men and the second leading cause of cancer-related deaths among men in the United States, and whereas approximately 190,000 men will be diagnosed with prostate cancer this year and over 33,000 will die from it, and whereas prostate cancer not only affects men but also affects their family and friends, and whereas prostate cancer is usually treatable if detected early, and whereas early stage prostate cancer usually has no symptoms, and whereas education regarding prostate cancer and early detection strategies is critical to saving lives and preserving and protecting our families and friends, and whereas Birmingham First Seventh-day Adventist Church, located at 3520 Lorna Road in Hoover, Alabama, would like to educate the public about the benefits of routine screening and early detection, and whereas men who discuss treatment options with their healthcare provider and with their family are more likely to make good treatment decisions, and whereas all men are at risk for prostate cancer, therefore, the Honorable Mayor encourages the citizens of Hoover to increase their awareness of the importance of prostate cancer screening. Now, therefore, the Honorable Mayor, Frank V. Burcato, Mayor of the City of Hoover, does hereby proclaim October as Prostate Cancer Awareness Month in our city and encourage all men to learn about the risk and speak to their healthcare provider about screening for prostate cancer. In testimony whereof, the Honorable Mayor hereto has set his hand and caused to be affixed the Great Seal of the City of Hoover on October 5th, day of October 2020, year of our Lord. We now declare this Prostate Cancer Symposium open.
Thank you, Pastor Christian Ronalds, for sharing that declaration. I just want to prepare the audience to be ready for the first presentation. Just before I introduce our speaker, I just want to offer an opening prayer so we can be able to invite the Spirit of the Lord to guide us in this session. May we all have a word of prayer together. Heavenly loving Father, we are so grateful again. It's one opportunity that we have to be able to explore the wonderful creation that you have vested in us. We thank you for the systems that are functioning. We are wonderfully and fearfully made according to the Bible. And we just want to celebrate that even as we come together to share and interface in some of the challenges that men are experiencing, even as we continue to enjoy the blessing of life in this world. And so I just want to commit all the speakers in your hands, dear Lord, that you will guide us. I just want to commit the whole audience, both here and virtually, that we will have an interaction of mind through the wiring and the network of the Holy Spirit, that by the end of this session, we will say you've been with us. We ask that you will specifically be with every presenter here and guide them as they share these important facts and science, and as they help us to be able to live a better life, that we can also be men who you'll be grateful and you'll be delighted even to continue to be identified with. We ask these things in Jesus' name, amen. You know, one of my professors in school one time mentioned a very funny statement, that if there is something that God perhaps need to revise or that he may not have done very well, was the pelvic floor of a female patient, or just a female. I thought that was very interesting, that somebody thought that God did not necessarily do a finished work in the pelvic floor of the females. Of course, we do understand exactly the birth and all that, carrying baby for 9 months and delivery, which is quite a traumatic process, so to speak. And we kind of understand that our counterparts are struggling with some of their challenges in the urological field, which some of our doctors are dealing with that as well. But today, for a moment, we want to delve into the male organism to be able to understand exactly some of the challenges that bedevil the male's reproductive system, or urogenital, so to speak. And therefore, we are privileged today. Dr. Kyle Wood is going to be our first presenter to be able to explore the male's urological system and some of the problems that we're experiencing. And therefore, we're privileged to have him today. I just want to mention something. This event here and the presentation we have today is even more relevant to me, not just because of a man perhaps in that particular age when problems begin to knock on the door. But I just want to mention very quickly in a minute or two that I come from Africa, in a country called Kenya. And western part of Kenya is a group of ethnic group called the Kalenjins. All right? Now, interestingly, and those of you who are watching would be able to understand this, that almost in every household of the Kalenjin people, by the time the patriarch gets into the age of 70, to the age of 80, it is almost mandatory that they will have urinary retention. In fact, most of them have actually died for that. To the extent that we have almost believed that that is sort of a natural sequence of life among the Kalenjin people. And so, Dr. Wood, Dr. Adam, you got a task to be able to explore some of these issues, because some of us have actually sought to understand what exactly among the Kalenjin people is causing this to happen. Now, I'm saying this because the neighboring communities that are surrounding the Kalenjin people don't have this problem. And so we've wondered, is it diet? Is it something in the lifestyle? It could be genetics, but something has to have triggered this. And so these are some of the questions that many of us are beginning to explore, and that's why we have you guys as professionals to be able to explore this with us. Thank you very much for coming. Dr. Kyle Wood, you're welcome to take the stage to take us through this session, urological issues.
Thank you so much. So obviously, COVID has introduced an interesting dilemma for us, because we have to be able to communicate with the public and the healthcare industry now through many different mechanisms. So I'm so glad that I was invited to be able to give this talk and be able to communicate to the public some of the urology issues that we see. So I'm currently an assistant professor at the University of Alabama. My primary focus is on kidney stone disease. By 2 more years of training in kidney stone disease. And so I will touch on this kidney stone disease or urolithiasis. It's impossible to talk about prostate cancer without kind of talking about the prostate and some of the other things that men may experience, which is BPH. And so I would like to talk about that initially, and then go from there and talk about prostate cancer. I have no disclaimers for this talk. So just to begin, the human anatomy is quite complex. And when we talk about the urological organs, they do sit in different spots than most people think. So if I ask people, where do you think your kidneys lie? A lot of them will point to their belly or their abdomen. In reality, they sit in the back. So they're retroperitoneal, and they sit in the back underneath the rib cage. And so when we talk about kidneys, which is part of the urology, the genitourinary system, the kidneys will sit in the back. And so people can experience discomfort in the back, and it will actually be related to their kidney stone disease. As you can see in these images, the bladder sits really quite low. So a lot of times when people talk about their bladder or their prostate, what they're experiencing may be discomfort in the perineum region or the lower abdominal region. This is just a quick sketch of the way the kidneys drain into the bladder. So the kidneys have a conduit to the bladder called the ureter. It's a small tube that connects into the bladder. And in the bladder, the diagram to the right, you can see a picture there where the bladder, in its most simplistic explanation, is a storage container. Basically stores our urine to allow us to then hold it and not have to go to the bathroom all the time, and then allows us to pee when we need to pee. In that picture on the right, you can see this circular structure that sits just below the bladder, and that is the prostate. I try to describe to patients that come into me that the prostate is, in some ways, it's smaller than an apple, but it's similar to an apple in the sense that the core of the apple is actually your urethra. And that's the conduit from your bladder to the outside world where you pee. So now it's easy to understand why the prostate can lead to quite a bit of urinary dysfunction or urinary problems. And so when we look at all men greater than the age of 40, there's a lot of symptoms that they can experience, some of which can be related to the prostate. And so when we talk about benign prostatic hyperplasia, or commonly referred to as BPH in society, it can be due to enlargement of the prostate. It can be due to obstruction from the prostate. So the prostate may not actually be physiologically enlarged, but can cause enough to block that core of the apple that I was talking about to make it more difficult to urinate. And then it can also cause a whole bunch of dysfunction within the bladder. So you can have what we call LUTs, which is that bottom right-hand corner. And that's really lower urinary tract symptoms. And that's kind of a catchphrase for a lot of different things men may experience, which might be frequency, urgency, feeling like you have to go right away, trouble urinating, slow stream, and then that can lead to a certain amount of bother. So all of this becomes important when the urologist or a primary care doctor or a nurse practitioner or any healthcare provider is evaluating their male patients. They're going to ask about these urinary symptoms. And then to recognize that these urinary symptoms may be caused by a multitude of different diagnoses that may include prostate cancer but don't necessarily equate to prostate cancer. One thing to know about with BPH, or benign, meaning not cancer, prostatic hyperplasia, is that there is a family genetic component. We don't understand it completely, but we know that if you have first-degree relatives, or say a father with symptoms or a brother with symptoms, then that may put you at higher risk of having similar symptoms. So a lot of times having your family history and knowing what your father had experienced or your older brother had experienced may lead us to know a little bit more about your clinical diagnosis. In addition, prostate cancer has a family genetic component. So knowing that a first-degree male relative had prostate cancer can lead us down that path. This is just kind of a figure of what the prostate looks like. It gets quite complex, and so we try to think of the prostate as just a simple organ, but it is actually quite complex because it does allow, as I've said, the transit of urine through it, and then also it allows for ejaculation to go through it, right, which leads to fertility and pregnancy. And so it becomes quite a complex structure. There's multiple different regions of the prostate. And so when a patient comes into the office, they oftentimes ask me, how do you know if my prostate's abnormal? And as you saw in the video that led up to this conference about prostate cancer, there is some lab values that can be done, or blood draws, which can be PSA, or prostate-specific antigen. It's just a blood test that shows a marker of prostate. Those markers are imperfect, but helpful. So just because you have a high PSA does not mean you have prostate cancer. And some of that's due to the complexity of the organ. And so, for example, if you look to the picture to the right, the peripheral zone is where most prostate cancer will occur. And this is why your physician will offer you a rectal exam or a finger exam during your evaluation, because through that, we are able to feel the peripheral zone of the prostate. And if there's an abnormality in the peripheral zone, that may lead us to be more concerned about a diagnosis. The transition zone may be more related to, say, the BPH, or the benign prostatic hyperplasia, or the difficulty peeing. Again, that's a benign, it's not cancer, but can cause a lot of the similar symptoms. As Enos had talked about, a lot of prostate cancer is actually asymptomatic, meaning you actually don't have symptoms. And so that's why we talk about screening for prostate cancer, which I'll get into. So you can see here, if you just look at a quick chart, these are multiple publications, each of these lines, looking at different studies in different populations. And you can see the percent of prevalence, or the likelihood of having BPH, or prostate issues that are not cancer-related, go up as we get older. So as Enos had pointed out, as our population ages, we see more and more of this. People and men are living longer, and thus we're seeing more and more of these prostate issues. If you simply look at the very end of the curve, which is always fascinating to me, if you're over the age of 80, you have an 80 to 100% chance of having some level of prostate issues. So in some ways, it's not a disease in all senses, because we're all going to experience it if we live long enough, right? And so all of us are going to experience, all men are going to experience some symptoms with their prostate if they live long enough. But this is where urologists and other physicians come in handy, because we do have a lot of tools in our toolbox to treat the symptoms, and then also to determine if it's a benign problem of the prostate or a cancer that needs to be treated. And interestingly, in prostate cancer, it's changed over time. We used to take out anybody that was diagnosed with prostate cancer would typically undergo treatment with, say, radiation or surgery. And that's changed. We've realized that there is some prostate cancer that we can watch. And so I tell all my men that prostate cancer is a different type of cancer. Yes, it's one of the most common cancers in men, and yes, it is a leading cause of death in men. But most men can live with prostate cancer. They don't die from prostate cancer. And so looking at the patient's overall health, having an understanding of the risks and benefits of the procedures, the radiation, the different treatment modalities becomes important. And so it's not as simple as having cancer and then subsequently getting it removed. There's a lot of conversations that need to be involved there. This is just looking again at multiple different studies and the percentage of men that experience symptoms. And these are across the world. So if you just look, some of these studies have been done in Japan, some of them have been done in China. And basically what it shows is that as we get older, it's more likely that we are going to experience prostate issues. And so that all becomes important again. And with prostate cancer, that's a similar thing. If you look at so BPH increases as we get older, but also the chances of us being diagnosed or having prostate cancer goes up as we get older. Interestingly, if you look at autopsy studies, so after people have passed away, if they have had an autopsy and they're being examined, if you look at prostates, a lot of men actually have prostate cancer, but it wasn't a problem, right? So we have to balance this again with knowing when to work people up and when to treat people, because again, if you take, say, a gentleman that's 100 years old that has passed away, and you do an autopsy on him, there's a high likelihood that he actually has prostate cancer in his prostate. But that wasn't the cause of his death. He maybe died of natural causes. And so we don't want to always go looking for things that we don't want to find necessarily. And then this just looks at volume of prostate. So again, when we looked at that picture of the prostate becomes an organ that can block our urinary flow and cause us symptoms. And this just shows the volume of the prostate, the size of the prostate. And as we get older, our size of our prostate gets larger. And so that's oftentimes maybe one of the factors that leads us to experience symptoms as we get older. So this looks at just lower urinary tract symptoms. And so one of the things to understand is that when we talk about men, there's these urinary tract symptoms, so frequency, urgency, trouble voiding, and even to the point that Enos said where gentlemen can't pee, and they go into what's called retention, and we actually have to place a catheter or a tube to drain their bladder. But these are all part of a group of things of causing bladder, I'll say, dysfunction or bladder symptoms. But in addition, there is other things with men that can be affected when we have BPH or prostate problems, and that can be erectile dysfunction, which is quite common and something that, as a urologist, we address often. And the more symptoms you have, lower urinary tract symptoms, the more likelihood of you having also erection issues. And that can lead to concerns from the patients that need to be addressed. And so we do look at the patient as a holistic approach. We talk about all of their symptoms, and in general, when we discuss with our men about the urological problems, we also look at the whole picture and try to understand all the symptoms that they're experiencing that may be related or unrelated to the prostate and address those. This is just a diagram to basically say it's not as, a lot of times we talk about the prostate and we think about it very simplistically, but there's a lot that goes into the urologist's thought process and how we work people up. And when we do certain studies and when we treat people with certain medications. And so there's a lot of algorithms that we use to try to lead us down a pathway to treat our patients. And so oftentimes you may come into the office and get a simple explanation. Oh, we need to get a lab test or take this medication. But in our brains, we're going through these algorithms, listening to your history, listening to your family history, listening to your symptoms, and that's guiding us down these pathways to lead us to what we think is an appropriate workup and treatment option. So for BPH, our benign prostatic hyperplasia, there are a lot of tools in our toolbox that aren't necessarily surgical, so they're medical, and they can be pills. And this is just a depiction. When we've looked at the science of this and we've looked at the organ, we realize there's a lot of receptors around certain areas of, say, the prostate and the bladder. And knowing that these receptors and what they are and how to, and designing medications that are specific to these receptors, we've allowed a lot of medications to come out there that we can help our patients, and we don't necessarily need to do surgery. If you look back 30 years ago, we were doing a lot of surgeries on people with enlarged prostate. And now, with the advent of new medications and the advances in science, we have now multiple medications that can prevent men from needing surgery. And that's the ultimate goal. I'm a urologist, I'm a surgeon, I do a lot of surgeries, that's what I do, but still for my patients, my ultimate goal is if they don't need surgery, I don't want them to have surgery. Because surgery carries risks, and there are benefits to surgery when we need to do it. This is just a quick overview of different medications that can be given for BPH. It's not all inclusive, but it does include quite a different, so if you go to your urologist and you complain of lower urinary tract symptoms and enlarged prostate, some of these medications may be the first line treatment in trying to help you out. And the side effect profiles are quite good, meaning that they don't affect patients that much. So, and we've gotten better, so you can look at just the bottom and you see the what it says, uroselective. And so understanding those classes of receptors that I showed you in the picture, and we've designed medications that are very specific to relieving the urological symptoms that people have. This is just one of them. I think a lot of men have heard about this drug. A lot of men potentially are on this drug. And it actually has quite a brilliant name from the pharmaceutical industry, which is Flomax, and maximizes your flow, right? So a lot of men experience nighttime issues where they're getting up a lot. They may have slow stream, and they might be going frequently, and Flomax may actually fix that issue. And this is just a study looking at as you go over time and you increase the dose. So the top line shows placebo, which is, for all intensive purposes, is just not a drug. It's a fake pill that looks like a drug that we give people in these trials so that we know that the drug is actually working and it's not just them seeing the doctor. And you can see as we increase the dose of this drug, the line goes down. That means that their symptoms are better. You don't really need to understand what the mean change is. That's just the drop in symptom score. We have a lot of, when you come into the office, oftentimes you'll fill out a form that lists all the symptoms and lists their scores. And so we look at a symptom score, and this is the drop in points, which means you have less symptoms. There are other medications like finasteride, which is the second one down. And that basically over time will shrink the prostate. But it also affects PSA. And so when we talk about prostate cancer, knowing whether a patient has been put on finasteride becomes important, because finasteride will actually decrease your PSA by 50%. But it doesn't necessarily mean it decreases your risk of prostate cancer. It actually doesn't. And so we need to know that, say, if your PSA score is a 3 when you're on finasteride, it's actually a 6 in our mind, which would be potentially abnormal based on your age and your prior PSA studies. And this graph just shows that we can use combination therapy. So there's different agents that work on different levels of the prostate, and we can combine them and decrease your symptoms. These are the surgeries. So oftentimes when we're seeing individuals in the urology office for BPH or benign prostatic hyperplasia, they've already failed medical treatment. They have tried medical therapy. They either failed it because they couldn't tolerate the medications, or their symptoms just never got better, and they're just miserable, for lack of a better word. And this is where these surgeries come in. And surgeries can be extremely helpful for patients, and it can change their life, but they do carry risks. And so as a surgeon, it's always good to talk about what things you can experience after surgery so that everybody's on the same page. In all of medicine, everything is a shared decision, right? So it's always talking with the patient, talking with their family if they want the family involved, and then also understanding the surgeon and making a shared decision about what they think is the best treatment modality, whether it's medication or whether it's surgery. The abbreviations on the top just represent different ways to treat the prostate. In reality, it's all pretty much the same. What you're trying to do is limit the amount of prostate tissue that's blocking the bladder from draining. So TURP, which is very common, and people know that term because it's the gold standard. It's what's been around, not the longest, but it's what's been around for a long time and been studied to a great deal. And that's transurethral. Again, the urethra is the conduit from the bladder to the outside world. So going transurethral, going in the urethra, resection of the prostate, and that's how you get TURP. And then all of them are similar. So TUNA is transurethral needle ablation. Okay? HOLEP is holmium laser enucleation of the prostate. And so you can see we have all these acronyms, but they're basically all just different surgical techniques. And they do have, some are better than the other. If you just look at the symptoms that you can experience afterwards, you can begin to see that some surgeries are better than the other. And so talking to the patient about what they're worried about post-surgery may lead you down a certain pathway in a treatment modality. And there's less invasive approaches and there's more invasive approaches. And this just looks at how, so I don't like to just show the symptoms that people may experience because of surgery. I also like to show the benefits. And so surgery does have, is highly beneficial. You can see in that top line, which is just decrease in AUA symptom score. So this is how many people actually experience a significant benefit from the surgery. And you can see the score drops by 71%. That's drastic. That may take a gentleman who's, say, 50 or 60 years old, and they will tell you they're voiding now like they were back when they were 20 years old. And so that can be a huge benefit for a gentleman that's experiencing horrible issues from their prostate. So that kind of leads to prostate cancer, which is obviously what this symposium was about. I do want to preface everything with, as I said before, that prostate cancer is always changing. It's probably one of the most studied cancers, and there is a lot of money that is being dedicated to research. And so what I always tell my patients is the good thing about prostate cancer is, again, most men can live with it. And we have treatments that can either cure you or allow you to live with prostate cancer. And every year, there's new information coming out. Every few years, there's a new drug that's coming out. And so I do think we're really tackling prostate cancer quite well. I think prostate cancer awareness has become more and more prominent, which I think is great. I think if we think about, say, something like the counterpart, I think in females may be, just from a research perspective, is breast cancer. We have gone leaps and bounds in the breast cancer world to be able to treat it, to know how to best treat it surgically, medically, with chemotherapy. And that's led to fantastic outcomes there. And prostate cancer is seeing similar benefits. But I do think even with breast cancer or prostate cancer, there is some level of societal concerns about talking about those organs, so the genital area or the symptoms that you may be experiencing. And so, you know, if there's anybody out there that's listening today, if there's any concerns, that's what urologists are here for, that's what physicians are here for. This is what we do day in, day out. And so the level of concern, it's not this is what we do, this is what we talk about. There's no discomfort from our side talking about these issues. So as Enos had pointed out, prostate cancer is extremely common. So it is, as you can see, the top line is prostate cancer. So when we compare prostate cancer to, say, lung cancer, colon cancer, bladder cancer, skin cancer, liver cancer, thyroid cancer, you can see prostate cancer, the rate is high, right? The incidence rates are so high. And what makes that interesting, though, you can see these spikes. So the reason why you see the spikes in the early 1990s is really the development of screening protocols with PSA. So all of a sudden, we came up with a tool to be able to detect prostate cancer, and you can see we had a huge rise in the number of people with prostate cancer. If you talk to urologists that are maybe towards the end of their careers, so in their 60s or 70s, they trained in a very different era than we've trained. Prostate cancer used to be a disease that only showed up at the very end stages. And so they had wards, full hospital floors, full of people with metastatic, meaning the cancer spread, prostate cancer. And these individuals were in an awful situation, right? They were dying from their cancer. There was no treatment options. Now, if you look at our generation of urologists, the younger generations, we don't have that same experience. We do see people with metastatic prostate cancer, but because of screening tools, because of awareness, it's a lot less common than it used to be. And so we're able to take now a disease that used to present and used to fill up hospital beds, and we have treatment modalities. You know, the Nobel Prizes were just announced in the news for different fields, but I always like to say, you know, there's not a lot of urologists that win Nobel Prizes, or not a lot of things in our field that advance to Nobel Prizes. But prostate cancer is one of them, right? So there was a Nobel Prize granted to Higgins for discovering that testosterone, which is, you know, the male dominant hormone, is a driver for prostate cancer. So when they discovered what we call androgen deprivation, and so what he described was removing the testicles, which were the source of testosterone, and pretty much stopping prostate cancer, or the progression of prostate cancer. And that won the Nobel Prize. So we think about all the advancements since then. The drugs we use now, that the pharmacists will potentially talk about, are all treating, in a lot of ways, testosterone. So if you have metastatic cancer now, we have drugs that block testosterone. And so it's quite fascinating in our world that that's where we're at now. And it all kind of was spearheaded by a Nobel Prize laureate that discovered that. There's still a lot that's not known. So this is just the incident rate and the mortality rate from prostate cancer. And this always shocks me, right? Because we try to think about our healthcare system in the US. We tout it as the best healthcare system, and we have multiple ways of treating people, but there's a lot of differences between the way prostate cancer presents and a lot of knowledge that we still yet to have, and it's multifactorial. There's more than one thing that's causing these changes. But you can see just quickly, this is the incidence, so the likelihood of having prostate cancer, and the mortality, the likelihood of dying from prostate cancer. And you can see the difference between race. So white, African American, you can see the mortality rate is 42% or 43%, whereas in the Caucasian population, it's 19%. So there's a lot of disparity there that we need to address. And the incidence rate is higher. So why does prostate cancer afflict the African American population more? And how do we effectively fix that problem? And how do we address that, make sure that screening is occurring in the appropriate scenario, but screening. So, you know, just quickly, screening is a tough word because we do talk about screening of prostate cancer. Screening, when we really discuss the true term screening, we're thinking about testing everybody or every male at, say, a certain age for prostate cancer. But the way we like to think about it in the urological world is it's not screening, it's shared decision-making, talking about the risks and benefits, and then performing an evaluation of that patient, which may include a blood test, if we deem it appropriate. So for example, if I have an 80-year-old gentleman who just had multiple heart attacks, that's probably not somebody I'm going to screen for prostate cancer, because as I'll talk about, people live with it, they don't die from it. And so we need to be careful with that. So this is just looking at the death rates. And so if you remember the curves that I showed you of the incidence, prostate cancer sits on the highest, but yet when you look at prostate cancer on this, it's much lower than, like, say, lung cancer. So we've unfortunately have all had experience with loved ones that have died from cancer. And so that word cancer scares us. And what I try to tell my patients in the office is prostate cancer is different. We do have to think about it as cancer, but we can cure that cancer. And people, even if they have prostate cancer that we can't fix surgically or with radiation, say, we can still treat them medically, and we can keep them alive and relatively symptom-free for a very long time. So it's unlike being diagnosed with, say, lung cancer or metastatic lung cancer, where survival time may be only, say, 6 to 12 months. Just like BPH that I showed, family history becomes important. And this is where that idea of screening, which again, we don't tend to like the word necessarily screening because it is shared decision making, but getting a good family history becomes important. And so these are just relative risks. So when you look at relative risk, all that means is how much more are you likely to be diagnosed with prostate cancer if you have one of these family risk factors. So if you have a father that was affected, your risk is, say, twofold or 2.5-fold, okay? If you have 2 or more first-degree relatives, say you had a brother that was older that was diagnosed with prostate cancer, and you know your father had treatment, that's 2 or more relatives, you have almost a 4 or 5-fold increase risk. So it becomes important, family history, and being aware. And again, it's not something that all families like to talk about. And so talking about your prostate and your experience can become important. This is just going again, saying that we are not always classifying people as they need surgery. Okay, so this is just classifying people as very low risk, favorable, unfavorable. And it's not important to understand this, but understand that the urologist or your caretaker is looking at all of this. So oftentimes when you have a high PSA, and high can be different based on your age group, the size of your prostate, and so there's a lot that goes into what we consider an abnormal PSA. But it may lead down to a prostate biopsy where we take samples of the prostate and look at whether you have prostate cancer. And then based on that, we may characterize you as different risk groups. And you can see that if you have say, a very low risk group, we may offer you surveillance where we watch you. We don't actually take your prostate out or treat it with radiation. So I just want you to recognize that although prostate cancer, the term itself is all-encompassing. It includes people that have very low-risk prostate cancer where you may not need any treatment. And then you might be a very high risk where you may need aggressive treatment. And then there's everything in between. And again, not all people with prostate cancer, as I said before, when autopsy studies are performed, as you get older, you're likely to have prostate cancer on your prostate. They didn't need treatment, obviously, because they died of something else. And so we need to be aware that not all people need treatment when they have prostate cancer discovered. But it's important to have this conversation. So this is where algorithms come in. Again, urologists, or at least my brain works, where I'm constantly thinking down certain pathways based on the way the patient's describing things and the way their family's describing things. And then treatment options change. There are surgeries, so I'm a urological surgeon, so we may offer to take your prostate out, which is a RALP, robotic-assisted laparoscopic prostatectomy. That's the most common way of performing it now, using the robotic platform. So, just quickly, robot's interesting because people think, oh, it's a robot, it's going to do it for you. It's a platform, it's a tool through which we use and engage to be able to perform our surgeries in hopes that we do it better for our patients, allow for less comorbidities after surgery or issues from surgery. So it's just a tool that we use. And so removing the prostate can be done multiple ways, including the robot. And then there's radiation. Those are the standard 2 treatments, but there's other treatments out there that can be offered and that are recognized by our groups as potentially safe, effective surgeries or options for patients. This is just saying, again, that some people don't actually need surgery if they have prostate cancer. These are active surveillance protocols from major institutions that we oftentimes follow at other institutions. So UAB, or University of Alabama, follows these. And so if you have low-grade prostate cancer, low-volume prostate cancer, we may tell you to go on active surveillance. So that kind of ends the prostate cancer. Again, I have to take this opportunity as an endourologist or a stone specialist to quickly touch on kidney stones. We used to call it a male-dominated disease, and so I felt it appropriate to bring it up. Women are catching up in their kidney stone prevalence. Kidney stones make up about 9 to 10% of the population down in the southeast. So Alabama is considered part of the stone belt, which is just an increased risk of kidney stones. And so I like to think of kidney stones as more than just a male-dominated disease or more than just an episodic disease. It's a chronic disease. If patients have ever experienced kidney stones, They say it's one of the worst experiences in their life. And the treatment options are pretty severe too. Nobody likes the surgery I do for kidney stones. I'll be honest, their symptoms can be quite a difficult surgery to get through, but we obviously do it for right reasons. Multiple different types of kidney stones. Calcium-based stones or calcium oxalate stones is the most common. This is just looking at, again, calcium oxalate's the most common, but when we talk about kidney stones, there's different types of kidney stones, which lead us to different treatments. And again, as I said, Alabama fits right in with the stone belt. So this is just looking at the prevalence. You can see the darkest bars, which include Alabama, greater than 13% prevalence, which is crazy to me. Diabetes is 10 or 11% of the population. Stone disease is 13% of the population in the Southeast, and yet we don't think about it the same way we think about diabetes. And unfortunately, we don't have the same number of treatments that we do. This just shows over time it's an increasing disease. It's horrible when people experience it. Part of it's due to our culture. So we are a population that's growing in size. So this is just looking at the obesity trends. And being in Alabama, we are one of the states that kind of leads the way with obesity, and we also lead the way with diabetes, which is the bottom picture. And that leads to increased kidney stone risk. And this just shows obesity increases your risk, waist circumference, body weight. Any way you look at it, it increases your risk of kidney stone. Diabetes increases your risk, hypertension increases your risk. That's why I said this is a part of the group of chronic diseases that affect stone disease. And so I try to look at the entire picture. Coronary artery disease, carotid artery disease, myocardial infarction, all linked to kidney stone risk. So kidney stones is just one factor of this problem that we're experiencing in this country, which is partly nutrition and partly dietary. And there's definitely some genetic components to it, but we are becoming a larger population. We are more likely to have diabetes. And a lot of it has to do with our diet, and diet does affect kidney stones. Think about what you take in is what you urinate out, and what you have in your urine is what causes kidney stones. So there's a lot of ways to prevent kidney stones. I'll just end with fluid intake is probably the best thing you can do. You're diluting out the bad molecules, preventing kidney stones. I always tell my patients, I don't really care what you drink, just drink more of it. With some caveats. Obviously, we tell people to drink 3 liters of fluid. We should not be drinking 3 liters of alcohol, right? That's just not a smart thing to do. But beer, alcohol, wine has been shown to decrease stone risk. So I tell people if they want to have a drink, that's okay. Coffee has been shown to decrease stone risk. So obviously our community, we're a working group. Coffee is a stimulant that allows us to get through our days. So coffee is okay. Things like almond milk may be a cause of kidney stones. So these novel milks that are nut-based may be increasing the risk of kidney stones. The dietary fads, the high-protein diets, can increase, the Atkins diet, can actually increase your risk of kidney stone disease. And then salt intake. Again, this is a product of our society. We consume way too much salt. And it's not so much the table salt that we have, it's the salt that's in our food. And so decreasing your salt intake can actually decrease your kidney stone risk drastically. And just to point out, these are all guideline statements, and these can all easily be found if you go to the AUA, the American Urological Association website. Just type in AUA or American. You can find all of these things. And there are multiple surgeries that we can perform to remove stones. Some people may be familiar with it. The far left is shockwave lithotripsy, where we break the stone up from the outside. Ureteroscopy is where we go up with cameras and we laser the stones. And then for patients that have the unfortunate issue of complex anatomy or very large stones, we can remove them through the back. So I think, that comes to the conclusion of my talk, but I'm opening up to questions if there's any questions about any 3 of those things or anything urologically based.
So we're gathering questions online, and therefore we want to encourage everybody to participate in this if you have any questions. If you look at the link, you actually have a place where you can actually go in and submit your questions. So we welcome those of you to take advantage of that. Now, I have several questions already that have come in, Dr. Kyle. The first one says, if urine flow goes from 10 to 6, should that be a concern for prostate cancer or just a prostate issue?
Yeah, I think that's a great question. Again, the way we think about it, so when people say 10 to 6, they're usually talking about their urine, the uroflow that's done in the office. We measure the amount of urine that comes out per second. And so 10 to 6, I think, is what they're addressing there. So that's a decreased flow rate, right? Yes, I think, there's always, prostate cancer is on the differential. I think, again, it's a holistic approach. It's looking at the patient's family history. Have they been screened, quote unquote, with a PSA before? What has that lab value been? Are they experiencing any other symptoms? So urinary tract infections that can cause, acute issues, medications. So, we're getting into cold season now. And so if you take something like Sudafed, you may actually have issues urinating. And so you can have a sudden decrease in your urinary flow that is purely driven on the medication that you're taking for symptom relief for other things, sinus congestion, say. So yes, the simple answer is yes, we think about it. It's part of the differential. And then the outside answer is no, in the sense that we look at everything that could be related, and it doesn't necessarily mean you have prostate cancer.
Another question, and we're getting questions coming online. Remember, we have a virtual audience, and therefore we're welcoming them, and questions are pouring in. If one has prostate cancer, what's happening in their body in terms of urological damage?
Damage? So I think there's two ways to think about this. So again, most prostate cancer is asymptomatic and localized to the prostate. So it may not be causing any urological problems per se, because it's part of that organ, but might not be blocking something. If you have prostate cancer that's causing urinary symptoms, it may be blocking your bladder, and so long-term damage, it can actually change the way your bladder deals with urine and your flow. And so even if, say, we remove your prostate, you may still have urinary issues because of that. So it can have long-term damage there. In the severe scenario, when you have metastatic cancer or prostate cancer that's spread, the most likely place it goes to is bones. And so you can have bone fractures, bone health issues. It can spread inside your lymph nodes, which can cause blockage of other organs, including your kidneys and urinary flow. So that can be long-term damage.
Thank you, sir. Please elaborate on active surveillance.
Yeah. So as I've said, screening's kind of taken on a new term in the urology field. We don't like necessarily use the word screening, because we're not taking every person that comes in and screening them for prostate cancer. So the guidelines just quickly state that if you're under 40 years old, you probably shouldn't be getting quote unquote screened with a PSA. In the studies, there's no benefit. If you are over the age of 40 and under the age of 55, and you have a high risk, strong family history or something, there may be some benefit, and so it's shared decision making. And then if you're above the age of 55 to 69, that's probably the population that most likely benefits from the quote-unquote screening. But again, it's a decision making. Over the age of 69, we really think about life expectancy. So if we think if you have other medical comorbidities that's going to lead to you living less than 10 to 15 years, you may not benefit from screening. Active surveillance is when you have prostate cancer, and we think that you can, for lack of a better way of saying it, outlive the actual prostate cancer that you have. And so it's not going to affect your long-term survival. Again, there are some prostate cancers that some of us don't think should be called prostate cancer, because so like low-grade Gleason 6 prostate cancer in one biopsy core, may only represent a very small volume disease, and so we may put you on active surveillance. What I do want to say about active surveillance is that you can always come off of it, right? So it's exactly that. It's actively surveilling our population. So if you have prostate cancer and you're under active surveillance, you're meeting with your urologist regularly, looking at your PSA changes, looking at exam changes, and we can always change you to a surgical intervention or radiation intervention. So active surveillance, to elaborate, is just watching closely our patients that have prostate cancer because we think we're going to hurt them more than help them with intervention.
I think you might have already answered this, Dr. Wood. When one is diagnosed, are you on death row?
No. So I always tell my patients, most men live with it, they don't die from it. And so you are not on death row. If you have localized prostate cancer, your cure rates are extremely high if you need surgery or radiation. High, in the 90 percentile, depending on what you. So it is not a death row. And even if the prostate cancer eventually, it's usually slow growing. And so even if you have prostate cancer that spreads, we can usually control it for years and years with the medication treatments we have. So no, it is not a death sentence.
The next two questions actually relate to me, and I think I can make a guess very accurately that the person who was asking the question comes from my culture. That's exactly what I had alluded earlier on. Is there a link between milk consumption and prostate cancer or BPH overall? And the question also goes further to say, are there any studies that have elucidated these? I think I would have also had a similar question looking at the largest, the China study that somehow seemed to have linked some milk protein, casein or casein, I think that's how to call it. Have you ran into any reliable studies that seem to, because again, I should elaborate to say that this Kenyan community that I described from where I come from, we almost believe that all the cattle are ours. As a matter of fact, back before the government took over to regulate and have peace, they would literally raid communities and bring their cows. And milk was pretty much the basic and essential diet. And so we don't know whether this has contributed into genetics of prostate cancer and all these retention that we're having in that population. Now, in addition to that, they like to add some charcoal to their milk before they consume. And the question is, could that also be an issue, perhaps contributing to this kind of high incidence of prostate issues or, generally speaking, BPH?
Yeah. So what I'll say is it's complicated. So no, milk products have not been linked to prostate cancer in the direct sense. There, as you've kind of pointed out, there are populations that have increased risk of prostate cancer in different dietary regions. So obviously the United States diet is different from, say, another part of the country. And there has been some suggestion that the different diets as they are made up can contribute to prostate cancer or BPH risk. What we do know is that there are some carcinogens that can cause increased risk of prostate cancer. And so there has to be obvious concern about exposure to certain things that could potentially cause prostate cancer. That being said, charcoal probably is not one of them, and I don't think there's a direct link there. The one that comes to mind are individuals that have served in Vietnam and were exposed to Agent Orange have increased risk of prostate cancer. And obviously that's our population right now that are coming of age that they have increased risk and are of the age group that it's becoming more prevalent. And so to answer the question, no, milk has not been shown to increase your risk of prostate cancer. Yes, diet plays a role, and we just don't know enough about it. And then to kind of do the flip side, a lot of the vitamin studies and the things that people take over the counter have not been shown to benefit for both BPH and prostate cancer.
Another question on testosterone. Is the connection with testosterone levels and prostate cancer incidence due to naturally occurring testosterone, or are the connections with supplemented testosterone? There's also a part B question on that. Are testosterone supplements associated with higher incidence of prostate cancers?
So it's a complex question again. So we know that, as I pointed out, the Nobel Prize laureate showed that prostate cancer responds to testosterone. You take it away, you take its fuel source away, at least initially. No. So the direct answer is no. So most of us believe that giving testosterone supplementation doesn't cause prostate cancer. It may make it more apparent because you've delivered a fuel source to the cancer to allow it to grow, but it doesn't necessarily cause prostate cancer. So I want to be clear about that. And we know that taking away testosterone or lowering testosterone treats prostate cancer. So a lot of our drugs that we use are what we call androgen blockade. So they either block and androgen is testosterone, right, for the simplistic way of thinking about it. And so, yes, testosterone is directly linked to prostate cancer, but no, in the sense that if you are somebody that might have slightly higher testosterone compared to your counterpart, you do not necessarily have increased prostate cancer. And if you're being supplemented for hypogonadism, so if you're diagnosed by your urologist as having low T, is what you'll see in the news, and you're being treated with testosterone, it does not increase your risk of having prostate cancer. Might allow us to detect it because it's adding a fuel source, but we don't think it causes prostate cancer.
And this will be the last one so far, although it just vibrated, so there's another one coming. But here's the question. Some people think they can eat healthy foods to prevent and also cure prostate cancer. Is this true?
So the studies that have been shown is that people can live longer. So if you have a healthy lifestyle with exercise, you can live longer with prostate cancer. So the answer is yes, right? If you are diagnosed with prostate cancer, it behooves you to become healthier, eat healthier, and exercise. That has been shown to add to long-term survival benefit. Like I have said, there's populations that have increased risk of prostate cancer, and there is probably a dietary contribution. So if you're not eating healthy, I don't think you can cure your prostate cancer with dietary intervention, but you can certainly affect the outcomes that you're going to have, and you can, if you live a healthy lifestyle, you can certainly reduce your risk of getting prostate cancer.
I see our time is not on our side. There are 3 more questions here. And I think this may have been answered, and perhaps we will end there. Is the cancer a deterioration of the organ? Is the prostate cancer deterioration of the organ? I don't know whether I understand that, deterioration or whatever the case may be. Yeah. Deterioration is how it's spelled. Mm-hmm.
So is the prostate cancer deteriorating the organ? So I guess I'll answer that because I'm not quite sure. So the simplistic way of thinking about it is it's a cell, prostate cell that has gone aberrant and caused cancer. As it grows and it lacks its regulation, it can deteriorate that prostate, okay, and cause obstruction of those things. I don't know quite exactly what the question was asking in that sense, but the regular part of the prostate's not deteriorating necessarily. That makes sense.
And the last one is, let me see here. When is it time to seek a second opinion?
I always tell my patients to get a second opinion. I think as a urologist, it's always good to look in the mirror and recognize that our knowledge is limited. And so I think if a patient's making a life decision and a decision about their care and a decision about, it's always of value to get a second opinion and to try to figure out, and we are all biased based on our training and about our knowledge base and about what we know, and there's a lot of unknowns. And again, it's about shared decision making. What the patient values and what the family values may not be what the surgeon values or the physician values. So second opinions are always key.
Well, thank you so much, Dr. Wood. Can we give a hand for him? And I have to apologize, I didn't even mention that actually we practice together at Cooper Green. As a matter of fact, I actually refer patients at primary care level to Dr. Wood at urology. I told him when I met, actually I called and I said, listen, we have a symposium we are planning, the church is counting on me to get some speakers. I don't know of any other urologist but you. And so he just told me, yes, I'll do it. And so I really have to appreciate that, that you're willing to come on such a short notice.
I appreciate that.
All right.
Thank you.
And along that line, I must also say that above and beyond simply accepting to facilitate these events, he was also gracious to contact Dr. Adams, who I'd never met before. We actually just met before today for the first time. Dr. Adam Baumgarten, I have to apologize if I screwed that up. Patients also screw my name big time, most of the, many fashions of saying that. They are both, by the way, associate professors at UAB, and so we're so glad to the University of Alabama for raising such quality specialists to be able to help, not just for presentations, but I'm sure that we're making a connection. And most of you virtually and right here, I'm sure that we're establishing a relationship with these providers so that down the road, if you have any need we can be able to connect with them for even further assistance if you have any complications. He's actually the professor of genital urinary reconstruction and prosthetic urology, pretty heavy terms. And so we're so glad that Dr. Adam is here for the first time again, like Dr. Wood. Again, I have to emphasize, we're making a relationship so that in subsequent events, we'll be able to have them not just to lecture, but also to support those of us who may be having those kind of needs. Again, we're so glad to have you. Take it over from here.
Thank you, Dr. Enos, for
Anytime,
having me.
sir.
And this is a great symposium, and I appreciate you all coming to hear us talk. My name is Adam Baumgarten. I'm an assistant professor at the University of Alabama, Birmingham. I do what we call reconstructive urology, which we treat patients who have had either side effects or complications from cancer treatments, whether it be from urologic cancers or other cancers from other specialties, and also some of the quality of life issues that affect men, such as erectile dysfunction or incontinence or leakage of urine and things of those nature. I also have no disclosures for this talk. So here's a little agenda of what we're going to talk about. You know, erectile dysfunction is very common among men above the age of 45 or 50. First, we're going to talk about what is erectile dysfunction and what causes it. And then we're going to talk about using erectile dysfunction as a health indicator for some other disease processes. And then we're going to delve into some of the treatment options that we have. I know most people just know about pills and what they see on TV, but there are a lot of treatment options that we can offer patients who don't respond to these types of treatments. So what is erectile dysfunction? Erectile dysfunction, and we call it ED for short, is the consistent inability to sustain an erection that is sufficient for sexual intercourse or for sexual activity. So this can come and manifest itself in a lot of different ways. It can be, one, the total inability to achieve an erection, or also the tendency to only sustain brief erections that are not, can't be successful for sexual intercourse, or sometimes men will just get partial erections, and that is also can be called erectile dysfunction. So some facts about erectile dysfunction. Erectile dysfunction is very, very common. Over 30 million men every year will experience erectile dysfunction, and this is over 25% of men over the age of 50. So 1 in 4 people will experience this problem, and I think that's why it's very important that we, a lot of men don't want to talk about these things, but there are a lot of good treatment options for patients who seek them. And erectile dysfunction is not normal. A lot of people come in and say, hey, I'm 60 years old, I'm getting some erectile dysfunction, it just must be because I'm getting older. Well, the real answer is it's not normal. And a lot of the reason is likely there's some underlying condition that is causing that, and a lot of times we can diagnose other conditions that people are presenting just with erectile dysfunction. And a lot of times we can not only treat their condition, but also treat their erectile dysfunction by treating their underlying condition. And in most cases, the erectile dysfunction can be overcome. We can treat it and get rid of it. So I think it's important to understand, some physiology, or how does an erection work, before we talk about why does it happen and how do we treat these things. So to get an erection, it's a lot more complicated than most people think. It requires the brain, the nerves, the heart, blood vessels, and hormones all to be intact and working together. And if those things aren't working together, or one piece of the puzzle is missing, then erectile dysfunction will happen. So blood flows into the penis, and you can see on the top 2 cylinders there are the erectile chambers, or the erectile bodies of the penis. And these engorge with blood, and the blood gets trapped in there, which results in an erection. And like I said, if you don't have the blood flow, which we'll talk about, or you don't have the ability to trap the blood in the penis, this will lead to erectile dysfunction. And like I said, research has shown over 80% of men that have erectile dysfunction, these issues can be traced to some problem or disorder that we can tease out and fix their erectile dysfunction. So some of these things that we'll talk a little bit in more detail are injuries such as a brain injury or brain tumors, spinal cord injuries, disease processes, and these are probably the most common: diabetes, heart disease, high blood pressure, hyperlipidemia or high cholesterol, certain treatments for certain cancers, one being prostate cancer, and why I think this is very important to talk about in this symposium. Prostate cancer, whether it be prostatectomy or removal of the prostate, also radiation treatment, can all lead to erectile dysfunction. And then substance use. Smoking has a high incidence of erectile dysfunction. Drugs, alcohol, and then certain medications can lead to erectile dysfunction also. So what are some risk factors for erectile dysfunction? Like we said, chronic disease. So if a patient has diabetes, they're 4 times more likely to develop erectile dysfunction. And we'll go into this a little more in detail, but obviously the worse their diabetes is, or the worse their blood glucose level and sugar controls are, the higher likelihood they are to have erectile dysfunction. Prostate disease, and this is not meaning if you have prostate cancer you're going to have erectile dysfunction, but some of the treatment options can lead to erectile dysfunction. And also, like Dr. Wood talked about, BPH has a association with erectile dysfunction also. Peripheral vascular disease or cardiac problems, so patients who have issues with their blood vessels and can't deliver blood flow to the penis to get an erection. These are high incidence of erectile dysfunction. Hyperlipidemia or high cholesterol has a high incidence of erectile dysfunction, and also one of the most common being high blood pressure, and that's very common in our in the world today is high blood pressure. A lot of patients have this, and this can lead to erectile dysfunction also. So let's talk a little bit more about prostate cancer. So prostate cancer itself will not cause erectile dysfunction, but some of the treatment options that we offer, unfortunately, do have an incidence of erectile dysfunction. So let's talk about prostatectomy. When you remove the prostate for prostate cancer, the nerves that help deliver an erection run right along the prostate. So if we remove these nerves, sometimes this can lead to erectile dysfunction. And then radiation therapy, which is the other common treatment for prostate cancer, can damage the blood vessels and those nerves and decrease the blood flow and erections over time. Typically, with prostatectomy, patients have erectile dysfunction and these things get better over time. With radiation, typically, they don't see this erectile dysfunction for about a couple years after, and typically they get worse over time. Cardiovascular disease, like we talked about, the penis is a vascular organ and it requires blood flow to deliver an erection. Erectile dysfunction can be one of the first signs of cardiac disease or some type of cardiovascular disease because the blood vessels are very small in the penis, so they're one of the first affected. So some patients will come in with erectile dysfunction and we'll send them to a cardiologist and find out that they have significant heart issues. And the only reason we were able to diagnose that was because they came in for erectile dysfunction. So going back to diabetes, what risk factors of diabetes itself increase the risk of erectile dysfunction? One, as people age, their erectile dysfunction can get worse, and that's not from aging itself, but that's just associated with diabetes in these studies. How long they've had diabetes, because these over time can affect the nerves. Poor glycemic control or hemoglobin A1C, which is how well your diabetes is controlled over a period of time. And then in patients who have neuropathy or complications of diabetes are at higher incidence of erectile dysfunction. And then next, hypertension, so high blood pressure, which a lot of men and women have, but looking at it as for erectile dysfunction, in this study, in 104 patients over the age of 35, 68% of them, which is a huge number, reported some erectile dysfunction, and 45% of them reported severe erectile dysfunction. So, these all go back to blood flow and the blood vessels, and it's very multifactorial, very complex. cardiovascular disease, like we talked about before. This is more looking at the heart, but the heart is the driver of blood flow, so if there's some cardiovascular issue, it can affect erections. And then aging, like we talked about, as men get older, it's not that they should lose their erections, but they're at increased prevalence of having diabetes, high blood pressure, high cholesterol, and these things. And also there's some psychological issues as men age and how these relate to sexual function that we can see some patients coming in with erectile dysfunction. And lastly, smoking and medications. Smoking increases erectile dysfunction over twofold, so over 200%. And this also, the smoking, like it does in the heart, it affects the blood vessels and can make there be plaques and things like that that can contribute to erectile dysfunction. And then some common medications that we use to treat high blood pressure, such as thiazide diuretics, or like water pills, as a lot of people call them, or beta blockers, which is also a blood pressure medication that helps the heart, can also contribute to erectile dysfunction. So as we can see, there's a lot of men that will experience erectile dysfunction. And what are the ways that we're treating these things these days? A long time ago, all we had to offer these patients was the blue pill, or Viagra, as a lot of people had seen on TV. But now there's a lot of different treatment options than just pills, and a lot of different pills that we can offer our patients. So the first and standard of care is oral drug therapy. And why is that? One, it's just a medication. It's not a surgery. It's minimally invasive, or it's non-invasive. And the big thing is, over the last 5 years, we've had a lot of new medications come out. And also, a lot of these medications that used to cost $30 or $40 a pill have gone generic, and now they cost $1 or $2 a pill. So a lot of people used to come in saying, I can't afford the medications. Now there's ways to get these medications for almost only $1 a pill and not $30 or $40 a pill. But they do have some drawbacks. One, 30% of men won't respond to them, or their erectile dysfunction is too bad, and their blood vessels in their penis are too bad to respond to these medications. They don't give an automatic erection. They still, you need excitement and things like that. So a lot of patients come in, they said, hey, I took the pill and nothing happened, but you still need the normal excitement for these things to work. And then they have some side effects. The one major contraindication for these medications are patients who are on a certain medication called nitrates, or medications for a certain medication for the heart, such as nitroglycerin, or some blood pressure medications that are nitrates, that you can't take these medications because it could be life-threatening. If you're not on one of those medications, most men are good candidates for these pills. But they can have side effects such as headaches, facial blushing, upset stomach. Some patients will kind of see a blue-green hue sometimes, but usually these medications have very few side effects and are very well tolerated. So, like I said, 30% of men won't respond to these medications. So what do we offer these medications? And we have a plethora of options, and some are more invasive than others. But one is something called a vacuum erection device, which is basically a vacuum that is put on the penis and helps draw blood into the penis, and then a constrictive band is put on to keep that blood in the penis. The good things about this is, it's minimally invasive or non-invasive. It's safe. It doesn't require any drugs. It's cheap. There's training and videos on how to use these things. But it has some disadvantages. Some patients will say it's uncomfortable. Some of the ejaculation's not always normal, and the erection's not always warm to the touch. It can be cold. Next is penile injection therapy, which some men, cringe at the thought of, but some men say, hey, this isn't that big of a deal if I don't need to have surgery for something like this. So what this is pretty much, it's like the same medications as the Viagra and Cialis, but more in a liquid form that is injected directly into the penis with a very small needle, like you would give insulin or something like that with. And it induces direct blood flow to the penis, as opposed to when you take a pill, it has to pass through the GI system and get metabolized. This brings blood flow right into the penis. And this works very well for most patients that fail some of the other therapies we were talking about. It does have its disadvantages, and the number one being, a lot of men don't like sticking a needle into their penis. Others are, it can cause some curvature issues with the penis over time. It requires training. It can have some pain. Some men can have issues with bleeding, especially if they're on blood thinners. And there is a small risk of something called a priapism, or the erection lasting more than 4 hours, which requires emergency treatment in the hospital. And then lastly, we have some surgical options that we can provide our patients, something called an inflatable penile prosthesis. And these are complex devices that reconstructive urologists like myself and some others in the state of Alabama do. And they implant a device that's totally concealed in the body that can help you mimic erections. So what this device includes is it's 3 components. One is a reservoir, a fluid-filled balloon that goes under the abdominal wall. One are 2 cylinders that go in those erectile bodies that we were talking about before. And then there's a pump that goes in the scrotum. Everything is concealed within the body, so nothing can be seen from outside the body. And when a patient wants an erection, they pump the pump in their scrotum, and fluid from that reservoir is transferred into the 2 cylinders in the erectile bodies, and it delivers an erection. And then when they don't want an erection anymore, there's a button in the scrotum they push, and that fluid goes away. The benefits of this, it's a little more, it feels natural, and it maintains that spontaneity where you don't need to inject something or take a pill. You can use it when you want, and you don't need to plan for these things. So some questions that we get a lot from patients and a lot of these seminars is does it feel the same for me and my partner? Is ejaculation and things like that the same? And all of these things are intact when you have a device like this. Everything is normal, except it's more of a mechanical way of getting an erection as opposed to just from excitement and stimulation. And then, like Dr. Wood said, every surgery has risks, and we don't want to operate on people unless we really have to. So the risks of getting a device like this is, the number one would be infection. It's a foreign body put into the body, into the human body. So some bodies want to fight this device off. That doesn't happen very often, about 1 to 3% of the time, but that is a risk of the procedure, and it does require removing the device if that happens. And the other big one is, these are prosthetic devices, and over time they can malfunction, or parts of them can break. What that means is they would have to come and have another procedure to put a new device in. There's no shelf life on these devices. They can stay in forever if they are working, but the companies that make these devices usually say the average device should last around 10 years, and then patients will likely need a new device. There are some devices that I've seen in practice that have lasted 30 years, and I've also seen some last a year, and that might be because of some user error, or unfortunately that device had some issue on the onset that was exacerbated over time. So that's all I have prepared today. I know there's likely going to be a lot of questions about this, and I'm happy to answer any questions at this time.
Oh yeah, we're getting quite some questions here. The first one here, pardon me, because a lot of them I have to screen to see which ones we've responded to and which ones we have not. So the first one talks about if the man has ED, and you might have already addressed that, due to underlying conditions, what is your strategy for a good outcome?
So obviously, we like to take the whole patient into, in concern. So we don't just treat their ED. If they have some underlying cardiac issue that has not been treated, especially being at UAB, we have a lot of different partners and a lot of different specialties. So we'll refer them to a cardiologist. We'll make sure they have a good primary care, taking care of them, checking their blood pressures, checking all their lab values to see if we can address some of those things. And a lot of times, if we can fix the underlying condition, if we can control their diabetes or control their blood pressure issues, then their erections will get better without any medications or anything like that.
Good. And here's another one. Removal destroys the defining features of the male species. I guess removal of the prostate implied. Men say, I feel like a walking dead. Why life if I feel like die?
So,
Yeah, I think, and this is a question that I think has been a very big concern to a lot of patients because they understand that on the other side of surgery, pretty much a lot of issues. And sometimes they wonder, is it better to just keep the problems that I have and still kind of function somehow, whatever long it can happen, or do I just go through the whole procedure?
Right.
And then on the other side, I'm dealing with ED, incontinence, and all that.
Yeah, so I think that's a very important question. I think 30 years ago, we didn't have a lot of these things that we can treat these ED and incontinence with that we do today. One, with prostatectomies now being done robotically, these things aren't as common as they used to be. With open prostatectomies, 20, 30 years ago, almost everyone would get some incontinence or some erectile dysfunction. Now, I would say only about 10% of men have incontinence to the point where they need some type of surgical treatment, okay? And erectile dysfunction, a lot of men may just need pills after surgery. But the good news is for those men that those things don't work, or they do have incontinence, or they do have erectile dysfunction, there are definitely ways that we can treat these to get them back to wherever, quality life things that are important to them, we can get them back to where they want to be.
Another question. Is there observable connection between vasectomies and ED? Actually, three questions together. Are there any negative side effects to vasectomies? And the third piece of that is, are vasectomies reversible?
So there is no known connection between vasectomy and erectile dysfunction. Vasectomy, what was the second question about side effects?
Yes, negative side effects
to vasectomies. Very few negative side effects. There are very few patients, less than 1 or 2%, that will have chronic pain after vasectomy. But that's very uncommon in men that have vasectomy. And the last was...
Is it reversible?
Vasectomies are reversible. But if you are thinking about vasectomy, you should be definitely clear that that's something you want to do, because the success of reversal is not great. It's under probably 50%. And as the time period goes on, from the time of vasectomy, it becomes less and less. So men who are 10 or 15 years out from vasectomy, there's not a great chance that a vasectomy reversal will produce a pregnancy.
Wow, so somebody has to think hard before deciding to undergo the procedure.
Yeah.
That seems to be the implication of that answer. Another one just came in right now. What happened to a patient with long-term use of oral therapy? What happened to a man who uses the pill recreationally? They use it but don't need it. I just read the way it is.
Okay. So I would say if men don't need, if they have good erections and don't need medications, they shouldn't use them, because like I said, they do have side effects. And I think from a thinking psychologically, some men become dependent on them that don't need them. So they'll say, oh, I took pills and my erections were great, but they didn't need them. But then, they run out of pills and they should have normal erections, but psychologically, they can't get them because they're dependent on these medications. So I'd say it's not something that should be taken recreationally, only if patients need them.
I think that is the list that I have here. If you get any other questions in the course of presentation, we may just go ahead and route them to the doctors and see if we are left with some time down the road before the close of this event. I want to thank you, Dr. Adam, for being a part of this.
Thanks for having me.
Sure, we will be having you more, in the subsequent events, now that this place has now been declared a center for men's health awareness. God bless you.
Thank you.
I know we still have some time. Just another question came in. Are there any rejection issues requiring ongoing medication with the ED implants that you mentioned? I'm sorry, we have to bring you back again. Are there any rejection issues? Yes, requiring ongoing medication with ED implants that you mentioned. I guess rejection of the implant itself.
So no, but they can have infection. So about 1 to 3% of patients will develop an infection requiring the removal of the device, and usually that's soon after surgery. And there are things we do by giving antibiotic before and after, and making sure patients who are diabetics control their sugars and things like that, and their glucose levels to try and prevent these infections. But there's no known, rejection from the implant itself, just infections.
Thank you so much for that segment. I'm sure it's been very, very informative. In case we are not exhaustive in this, I just want to make a commitment to say that anybody who either was electronically challenged and could not be able to get their question on time, or just could not be able to reach to us using this system of transmission of questions, I'll still welcome those questions. If I get them later on, I can still be able to route them to our doctors here. I have contact with them, and so I can always do that, and we can find a way to reach you. If you like, you can also post your email address, and we can actually direct the questions back to you. The answers back to you. All right, the next segment, we're going to the nutritional segment of things. Robbie Lewis is a registered dietitian. Yes. I'm sorry. Oh, David is coming. Okay. All right. Thanks for that notification. I wasn't sure that there was a... All right, so now the drug man comes in. David Armstrong. People have questions about natural supplements, alternative therapies, complementary therapies, side effects of even the mainstream medication that I think we kind of went through. Dr. Wood kind of mentioned quite a bit of those and all that. And so we are blessed that David Armstrong is a member of this congregation. And he's been very, very helpful every time that we have concerns about medication. He's the guy that can be able to break things down in terms of side effects of medication and all that. And so David will take it up from here to be able to answer some of your questions and clarify some things about medications. Yes. Go ahead,
Okay.
David.
Thank you, Enos.
Sure.
I'm going to stand. I'm a pharmacist. I can't sit. I'm used to standing. So we'll get started. Today I'm going to talk about some pharmacotherapy as it pertains to prostate cancer, prostate issues in general. And the doctors have already touched on some of these things. I'm just going to go into a little bit more depth, but basically we're going to move on here. So let's see. We working? Oh, there we go. So I'm going to talk about 3 issues that are common to men with prostate. We have a prostatitis, which is an inflammation of the prostate, BPH, which we've already touched on, and prostate cancer. As we talk about it, again, I'm going to go look at this anatomy real quick. It's just a real simple diagram here. You have the bladder, and then you have the urethral opening coming down and the prostate, which surrounds it in men. Now, when that prostate gets some type of problem or issue, or as it grows, as Dr. Wood said, it cuts off the supply of the urine from the bladder, and you get all kinds of problems or issues. So prostatitis, we'll touch on this real quick. This is simply an inflammation of the prostate gland, and it can be caused by bacterial infection. It can be acute, it can be chronic, but the way you would treat it would depend on what caused it. Now, it also can be caused by some traumatic issue that you had some trauma to the prostate. So risk factors, oddly enough, when having prostatitis, it's not really age-related. Being middle-aged or young, you see this in a lot of men who have prostatitis. And they could have had prostatitis previously. They could have an infection of the bladder that's caused by a catheter or catheterization, bicycle riding, some type of trauma, horseback riding, and just looking at a multitude of these things can cause prostatitis. Even having a prostate biopsy can cause prostatitis, an infection of the prostate. And again, here's some symptoms you see with prostatitis. Now, these symptoms, if you have any of these symptoms, you really want to get checked out, because it could be, again, these symptoms could emulate or be the same as prostate BPH or BP or cancer. We wouldn't know. So how would you treat it? Well, obviously you need to go to the doctor and you need to get it checked out and let him do either an exam or a urine sample and see if you have some type of infection. Okay, so here's some antibiotics that we commonly use to treat prostatitis. You've probably heard of some of these, but these are just mainstays. And just taking them twice a day is normally the dosage we do with that. And the cost of these medications have come down tremendously. So if you don't have insurance, they're fairly affordable. And when you take these antibiotics, you have to remember that the acute prostatitis can be treated, but it's usually a 2 to 6 week process for acute prostatitis. If we do chronic prostatitis, it's going to take a little bit longer. You may go 4 to 8 weeks. So when you're taking these antibiotics, you want to make sure you finish them all, even though you start feeling better. A lot of our tendency is, oh, I feel good, the prostatitis is gone, I'm fine, but guess what? It comes back on you. And this can be a big problem. We see this in our practice a lot. It's really hard to treat prostatitis, the prostate, because it's hard for the antibiotics to penetrate into the prostate gland. So you want to make sure you do follow up and finish all. And also you're going to get some side effects with these antibiotics. Nausea, diarrhea, vomiting can be a big one. And when you get these side effects, your tendency is you want to stop taking them. But don't do that. You always want to communicate with your doctor. Now there's some other side effects that you get with these antibiotics, such as photosensitivity. If you're in the summer and you're taking these antibiotics, you want to watch your sunlight. You can get burned real easy. Some of these drugs can cause tendon tears, allergic reaction, and actually damage your kidneys. So you want to speak with your pharmacist when you're taking these antibiotics and make sure you're taking them correctly. And there's ways to offset these side effects, and these are just common we talk about with our patients. Take with food is a good way to avoid some of the stomach stuff you get. Wear protective clothing in the sun or wear a sunblock. Drink plenty of water, that's important. Now when you take certain antibiotics, you want to avoid strenuous exercise because we can see tendon tears and tendon rupture with certain antibiotics, and we don't want that. You want to report any type of allergy you might have. If you're allergic to a certain antibiotic, that could be dangerous. And another thing you want to do to avoid some of the nausea and the stomach side effects you get is just take a probiotic in between your doses of your antibiotic. So you don't want to take them with the antibiotic, but maybe in a 2 to 6 hour, or 2 to 3 hour window, take a probiotic. Now, if your prostatitis is not caused by an infection, you may not need an antibiotic. You just may need some of these things like an NSAID, which is something like ibuprofen, Aleve, something to stop some of the inflammation. That might help you if you're not having an actual infection. We could take or do some, just some baths or just something to help ease the symptoms. And then also there's certain medications we can take to alleviate some of the symptoms, which Dr. Wood talked about earlier. We'll go over those too. And this kind of leads us into benign prostatic hypertrophy. And that's just where the prostate, again, we talked about, it gets bigger over time. And as it gets bigger, it actually will close off the urethra, and then you're going to get symptoms of not being able to void or go to urinate properly. So let's see what medications. Let's see. So again, as we get older, it's just a natural thing. Men's prostates usually get larger. This does not, however, mean you have prostate cancer. But if you're having these symptoms, you're not going to know again. So make sure you get checked out. And when you have these symptoms, which we've talked about earlier, just a hard time getting started, a weak stream, dribbling, you're not really getting complete void after you urinate, you're not feeling the actual relief that you should be feeling. And if you have urgent need to go, or you're getting up all night going to the bathroom, you might want to start with some medication, but again, you have to speak to your doctor. We talked about these alpha blockers. There's just a couple of these here that you're familiar with. Cardura, Flomax we talked about. Again, one of the side effects, the major side effects we see with this particular antibiotic are these. They're not that bad, but they can be. We call it a first dose effect. When you start taking these medications, you can have some dizziness, especially when you are sitting or lying in position. You stand up very quickly, your blood pressure tends to bottom out. and that's when you can be at risk for a fall. Now, these do attenuate over time. If you've taken the medication longer and longer, it will go away eventually. But one of the things you might want to do if you take these is take them in the evening and when you go to bed. Now, look at the cost of these things. They're fairly cheap. These are what we charge at our pharmacy if you don't have insurance, and if you do have insurance, you'll probably pay less. And again, the other group of drugs was the Proscar and the Avodart, and these are just coming at it from a different direction to shrink the prostate. Now, obviously, if you're having a prostate issue and you need relief, you need to go to the bathroom, you want to be able to go quickly. So you would take the first group of medications first, and then maybe take these two, but you can't wait 6 months to go to the bathroom. So you want to get that first, like the Flomax, you want to take it first, and the doctor may combine these two medications so that you get double relief from your prostatic hypertrophy. But again, we talked about all the side effects. Side effects include sexual dysfunction, infertility, mood disorders. We get what we call gynecomastia, enlargement of breast tissue, which is not something that men want to deal with. But one of the good side effects of these drugs is actually, and you've probably heard of this drug called Propecia, which is actually a derivative of Proscar. It's just a smaller dose, which you actually get sort of a, I wouldn't call it a cure for male pattern baldness, but it helps with male pattern baldness because you're blocking some of the testosterone hormone that causes male pattern baldness. So again, combination drug therapy is good to use for BPH. And then there is one ED drug called Cialis. I'm sure you've heard of that one. This one actually can be taken as a daily dose. It's not just taken at the time of sexual intercourse, but you can take it as a daily dose in a lower dosage form. And you get the best of both worlds. You get some treatment for your BPH, and you also get, you know, some of this treatment for the BPH, and also for sexual dysfunction. So you're killing two birds with one stone. And again, the doctor pointed out, these are not as expensive as they used to be. They've come down a lot. So if you don't have insurance, you're looking at a $40 to $90 cost for 90 days. But a lot of insurance companies will cover it, with the exception of Propecia. It doesn't cover Propecia because it's used more cosmetically. But Proscar, which is a higher dose of the Propecia, is covered. And if you were to take that, you would get even more effect with the hair growth. And then again, the ED drugs we talked about earlier. They were primarily used to treat pulmonary hypertension. That's what they came out for. And then they realized, I think Pfizer was the first, realized that you get this side effect, which is treating ED. And that started the whole wave of the blue pill and everything else. So just quick, I think this is dosage. People are always asking me, well, you take it 15 to 60 minutes before your activity, and the effects may last 4 to 12 hours with the Viagra Levitra. Cialis can be taken daily in lower doses, or you can take the dose as needed, and the effect usually lasts 24 to 36 hours. Again, we talked about the side effects of these things. Headache's the big thing, stomach pain, back pain. You don't want to give these to people who have heart disease, or you want to be careful in people who have heart disease, liver disease, and kidney disease. And again, nitroglycerins are definitely a no-no. And of course, cost. Everybody wants to know the cost, and they have come down tremendously. This is a big part of our business. We see a lot of men who want to get these drugs. So $1 a pill is about average. We talked about that, $30 to $60 for 30-day supply with Viagra and Cialis. Levitra has just come out generic, but it's still running about $600 or $700 for a 30-day supply. But it'll come down eventually. Yeah. The brand name, now I'll get guys that come in and want the brand name of this. You guys are not going to, I mean, they're $80 a pill now. I mean, it's ridiculous. But they'll pay it if they want it. So we talk about prostate cancer medications and treatments. And again, we know that prostate cancer is very common, but prostate cancer that is detected early, we want to keep it confined to the prostate gland. So when it's detected early, it has a better chance of successful treatment. Well, again, here, look at these symptoms. You see these same symptoms. So you got prostatitis, you got BPH and cancer. Well, how do you know which one you have? You don't unless you get checked out. So you got to see your doctor. This is very important. You want to be there to get your yearly exams. You shouldn't be afraid of that. I do it. I don't like it, but I do it. And you always want to make an appointment and make sure you stay up with your exams. So this group of drugs right here, basically, all you need to know is these are hormones, and the doctor talked about this too also. You're essentially putting hormones into your body to shut down your testosterone production. And this is what you do when you have prostate cancer. And it's an unfortunate thing, but it does work. It helps because the testosterone fuels the cancer cells and fuels the prostate gland. These drugs will essentially block the testosterone. So, you know, again, this is called androgen suppression therapy. The doctor talked about it. The two major hormones are testosterone and dihydrotestosterone. And these are just the first group of drugs I showed you before were basically given by implant or injection. And then these drugs can actually be given by pill, and they're a little bit more convenient. But either way, they stop the androgens from working, so they shut down your testosterone. We're going to get some nasty side effects from these, but that's just part of it. As you can see up here on the screen, there's not very pleasant. Your manhood is essentially blocked out. You'll see reduced absent sexual desire, erectile dysfunction, shrinkage, hot flashes, breast tenderness, bone loss, osteoporosis, anemia, decreased mental sharpness, loss of muscle mass, fatigue, depression. Yeah, so any of these side effects you're going to encounter. Now, there are things you can do to help with these symptoms. They can be treated with certain antidepressants, other drugs that can help depression, radiation treatment to prevent the breast tissue, several drugs that can help with osteoporosis. Depression can be treated, of course, with antidepressants. And then, but one of the main things you can do if you are diagnosed with prostate cancer is exercise. I think the doctor pointed that out. It's very important. You can reduce many of these side effects, including fatigue, weight gain, and bone loss, and muscle mass. And like he said, you know, prostate cancer is not a death sentence, so you can live with it, and you can, you know, try to stay as healthy as you can. And again, chemotherapy. Just remember that chemotherapy is used when prostate cancer is spread outside the prostate gland. And remember that chemo is not a cure or, you know, a standard treatment for early prostate cancer. There's a couple of drugs here, or a few drugs here. I'm not going to go into all this, but mainly you just know that you use these drugs for chemotherapy with prostate cancer, starting from the top. If that doesn't work, you move to the next and the next and the next. And a lot of times when you take these chemo drugs, you will combine it with a steroid, such as a corticosteroid, such as prednisone, to get the treatment. But they have been shown to help men live longer on average and slow the cancer's growth down, so there is some benefit to it. But still, chemo is very unlikely to cure prostate cancer. And then how do we give chemotherapy? Usually it's given through an IV, or it's given through the vein through an infusion and through a clinic or a doctor's office or some type of medical setting. You know that chemo is given in cycles. They usually give it for a 2 or 3 week period. They give you a resting period to give you a chance to recover. The length of treatment of advanced prostate cancer is based on how well it is working and what side effects you have. And again, the side effects of chemotherapy are unpleasant. Hair loss, mouth sores, loss of appetite, nausea and vomiting, diarrhea, increased chance of infections, bruising and bleeding, and fatigue. Of course, these go away once you stop the treatments. And there's also drugs we can always give you through the treatments, especially drugs for nausea and vomiting, that can help you get through the treatments. And I don't think anyone's discussed this. I know this is the future of cancer, immunotherapy for prostate. And immunotherapy in cancer in general is something that's the future, and I think it's here now. They're using it in some cancers, but it's using medicines to stimulate your own immune system to fight off cancers and more effectively and efficiently, so you avoid destruction of all your cells and just target the cancer cells. And this is going to be a great way to help treat prostate cancer. We talked about some over-the-counter medications. Antihistamines, again, cold and flu season, antihistamines are a no-no if you can help it, because that can definitely cause, like Benadryl can cause you to have urinary retention and give you symptoms of BPH, decongestants, probably not good, Sudafed. And we talked about NSAIDs earlier, non-steroidals. Those are good in a way, they're double-edged, but they also they're good in that they decrease the inflammation of the prostate, but at the same time they cause urinary retention through the kidneys because they're not good on your kidneys. So you can actually exacerbate your symptoms. So if you're taking a lot of non-steroidals such as ibuprofen, Aleve, Advil, or you're on something for arthritis, you got to watch that if you have BPH. Prescription medications that affect BPH and prostate issues. Obviously, if you're on a blood pressure medication called diuretics, these are used to decrease or to get the fluid out of your body, so it's going to increase your urinary output. And they use these for blood pressure issues and heart failure, liver disease, glaucoma. But the bad thing about it is if you have any type of prostate issue, it's going to exacerbate it. Caffeine is probably not a good idea. Caffeine is a diuretic, and it can cause some increase in prostate symptoms if you do too much caffeine. And then, of course, administration of exogenous steroids, anabolic steroids. We hear a lot about low testosterone these days in older men. So that's being touted as sort of the hormone replacement for men now instead of using it for women to make you youthful again. But at the same time, if you have a prostate issue, you would be fueling the prostate cancer cells or fueling your BPH problem. So you would want to watch it, or at least be sure you don't have any of those issues, and talk to your doctor before starting a low testosterone or replacement therapy. Antidepressants, some antidepressants that have been used over the years, if you're on an antidepressant for any reason, that could cause you to have increased symptoms of BPH and aggravate your prostate symptoms. So this is just a list of drugs here that you've probably all heard of. I'm not going to go into all that, but these are just some of the major ones we use for BPH. Alternative medicine, we can get into some alternative medicine. One thing that you can do if you're having prostate issues with BPH is biofeedback, and this is where you're using some techniques to relax those muscles in the pelvic region and to kind of get you to be able to void better. Acupuncture is, of course, one way that they use needles to go to certain pressure points to get that to the muscles to relax. And herbal remedies and supplements. I know there's a lot of questions about herbal remedies and supplements that have been touted. I want to talk about this for a second. There are many natural remedies on the market for enlarged prostates. According to the American Urological Association, currently does not recommend any herbal therapy for managing BPH. But if you do want to take it, make sure you talk to your doctor first, because that is important. So I'm not going to tout this as a cure-all for everything. However, there are some studies that show that saw palmetto has been used for centuries for prostate issues, and they have you see different studies that say, yeah, it works, and it may not. A lot of men take it to try to help with the symptoms of BPH. They say that some studies say it does work. But you get the anti-inflammatory properties and the hormone blocking properties a little bit, so it does tend to alleviate the symptoms of BPH. And here's some beta-sitosterol. This comes from actually pumpkin seeds, and they say that this one can actually alleviate some of the symptoms of BPH. Pygeum is another supplement. and stinging nettle. These two also help alleviate some of the symptoms, but they do cause some upset stomach and headache. And then lycopene is another just natural occurring substance. You see it a lot in fruits and vegetables, mainly tomatoes have a rich source of lycopene. There is some studies that show that it might help slow the progression of BPH. And green tea is another that has a lot of antioxidants and catechins, which have shown to help with the immune system and the progression of prostate cancer. But again, it has caffeine in it, so you don't want to do too much caffeine. And just taking supplements outside like zinc and vitamin E and selenium, you got to be careful with that now, because lately they've been saying that they've been seeing different studies that can actually make matters worse in prostate cancer. Before it was touted as being a good thing to do, but probably just getting it out of your diet is the best way to take those, and not doing too much on the supplementation side. But studies with dietary supplements, I just want to reiterate, such as saw palmetto, lycopene, and beta-sitosterol, have mixed results. So always ask your doctor for advice on this. And there's one statement from Hippocrates that I always like. I really agree with him on this. He says, "Let food be thy medicine, and medicine be thy food." I think this is a God-inspired statement. So there's some lifestyle and home remedies you can do to help with your prostate symptoms. Just some common sense things, but limit your caffeine intake or limit your beverage intake in the evening. Obviously, the more you drink at night, you're going to be up all night going to the bathroom. Limit your caffeine and alcohol. Limit your over-the-counter decongestants during cold and flu season and antihistamines. When you have to go to the bathroom, go. Don't try to hold it. They even say schedule bathroom visits. Go on a regular schedule. Follow a healthy diet. I think that's very important. Stay active. Exercise is also very important. And then when you urinate, sometimes you might have to go a second time a few minutes later, so you could double void. And try to keep as warm as possible, because when you're cold, you tend to go to the bathroom more. Again, the best prescription for our lives is an acronym, and I don't know if you've ever heard of this, but it's called New Start. And it's just a way to live your life to avoid any type of diseases. And it's a good way to live a lifestyle that would help defeat any type of problems that we might be having through our health. Nutrition, exercise, water, sunshine, temperance, air, rest, and above all, trust in God. I think that's very important. God is the ultimate physician. He is the one that can cure us. We have all this technology, we have all these medicines, as you see, but they all have side effects. If we live a healthy lifestyle to begin with, and we try not to be Alabama, and we try to go outside and, try to do what God tells us to do, I think we'll be in a better spot overall. Remember the original diet. And I think science is catching up with that too. The original diet is found in Genesis 1:29, and we just want to remember that God just primarily wants us to be on a vegetarian diet. I think science is telling us now that the more vegetables we put in our diet, the less fat, the less manufactured food, the less chemicals we put in our body, I think we're going to live better. Bottom line, healthy habits, such as regular exercise, watching your waistline, eating vegetables and fruit, and keeping an eye on dietary fat. These are going to help you with BPH. You're going to lower your risk of high cholesterol, of erectile dysfunction, diabetes, heart disease. So if we live this way, we're probably going to avoid some of these problems we're having right now. So I thank you for your time, and God bless.
A few questions for you, David.
Yes.
You've answered some, so I just wanted to combine everything. There's a question about polypharmacy. How do you help, with that, especially because patients are getting this pill for that and this pill for that before they realize they have a lot of medication. Right. So you touched on that, but now, over the counter, I think you covered that very well. But there's a question that says that there's some medication that are sold in the gas station. And I understand they're selling like hotcake.
Don't buy no medications from the gas station. Please don't buy medications from the gas station. Yeah, I know what you mean. Which one is those? Are those? You know?
No names are mentioned here. But
Okay.
I think there are a bunch of them that are sold.
Like ephedrine or those. I know the bath salts they sold for a while at the gas station. There was all kinds of strange things they were.
I don't have names. You might have to visit the gas station yourself and come up with names, perhaps, so you can address some of that. Actually, one time I looked at it, and there's no clear description of even what it is. But you know, I've talked to my patients who, of course, tell me that they're getting medication from there, and they say it actually works. But nobody, I mean, the safety profile is not even there, so you don't even know exactly what the components are. So,
and that's one of the major problems with herbal supplementation overall. They're not FDA regulated, so you don't know if you're there. You see thousands of different brands, and so when you're buying one saw palmetto from one company and you buy it from another company, there's no standard of measure there. So you don't know what you're actually getting. And that's one of the downfalls of supplementation. You don't, there's not a standard regulation as far as, you know, if you were going to buy a supplement, I guess the best thing to do would buy it from a reputable source if you can, but not the gas station. Yeah.
I'm trying to merge questions here so we can be able to take care of time. Of course, the ED medications are very expensive.
Well, no, they've come
alluded to
down.
that.
They've come down.
So the question says, how about the so-called Canadian or Mexican sort of market where people get their medication from? What do you think about it?
We're not seeing that as much anymore. They have actually come down. I mean, most of the sildenafil, which is the, you know, Viagra pill, you see it marketed about $1 a pill. So you can get, you know, quite a few for $30 now. So that kind of put a stop to that.
Now, my patients say that those, a lot of them think that those medications are not effective. I mean, you talk about, so they are saying they really want the real blue pill.
Well, that's because the generics are white; they're not blue, and so it's psychological. They see So if I paint them blue, they'll probably be, you know, it'll probably be more effective. But it is supposed to be chemically the same drug. But I do have a lot of men who use them, and they seem to say it works well. So.
I think for now we will leave it at that. Again, like I promised the audience, is that some of the questions that are coming late and others that we're not able to get to, especially because I still am getting questions about the prostate cancers and all that. Of course, our presenters have already addressed their sessions. I will make sure that we forward them so we can get answers, at least for this session. Thank you so much, David, for the presentation. There were questions about, to our doctors, you know, staging of cancer. How do you even establish whether it has escaped the capsule and begin to metastasize and all that? I think it's MRI and, you know, some additional testing to be able to do that, maybe PET scans if they've gone beyond the capsule. And now we're getting to the nutritional side of things. I understand that Robbie is here with us now. We're so glad that she has made it here. Robbie Lewis is a registered dietitian. She's worked in multiple places, including even OBGYN, to be able to help manage gestational diabetes. So she has a lot of experience in that as well. She's pretty much a nutritional educator and counselor. Robbie also actually has a company of her own, and therefore we want to have that relationship. Like I said, all our speakers here are not going to be strangers going forward. They will actually be partners with us to be able to deal with this. And so Robbie will tell us much about exactly the kind of counseling that she does nutritionally and the kind of business that she has to be able to support healthful living and eating healthy for good life, quality life, and longevity as well. It's our pleasure to have you today, Robbie, and take it from here.
Thank you so much for having me. Derek, you just led into the whole nutrition component, so I'm super excited to really expand a little bit on nutrition and how it relates to reducing your risk for prostate cancer and other prostate problems as well. Let me make sure I know how to use this thing. It works. All right, so today I'm just briefly going to go over best foods to help lower your risk for prostate cancer and other cancers as well. It's not just prostate that is out there. determine different lifestyle eating patterns that can help lower your risk for prostate cancer. And I'll also touch on different myths that you've probably heard of, and he actually touched on a few that I'm going to touch on today, and that kind of go along with specific prostate cancer supplements and food beliefs, so we can kind of learn a little bit more there. So looking at this picture right here, I hear a little laughter, giggles in the crowd. So I want you to look at this picture of the standard American diet, and I want you to think about the words that I'm about to say as I'm saying them. To reduce your risk of cancer, along with heart disease, stroke, and diabetes, eating a diet rich in fruits, vegetables, and whole grains with low amounts of sugar and red meat are the best nutritional strategies. Amen. So how does that stand up or stack up with the standard American diet? Do you see any fruits? Not exactly a fruit. I see a lot of sugar. I'm not going to ask what y'all had for lunch today to see if any of this fits into that or what you're having for dinner. Hopefully you have a plan. But ultimately, when reducing our risk for prostate cancer, as well as other cancers too, weight is a big component of that. So I want to tell you about a research study. In 2017, this was published in the Journal of National Cancer Institute, and its aim was to figure out if gaining weight raised the risk of fatal prostate cancer. So scientists tracked nearly 70,000 men in the prostate, lung, colorectal, and ovarian screening trial for 13 years, and those who were normal weight at the age of 20 and obese when they entered the trial at age 55 to 74 were twice as likely to die of prostate cancer than those who stayed at a normal weight. Those who were overweight at the age of 20 and were obese when they entered the trial later in their life had roughly 5.5 times the risk of dying from prostate cancer. So what should we do? Make sure we're at a healthy weight for our height, right? Don't gain any excess weight or lose weight if you need to. So as a brief summary of how we should be eating, you want to increase fruit and vegetable intake, replace your refined grains or your white breads or your white rice with whole grains, reduce your sugar intake, reduce red meat, which is pork and beef, and any poultry skin just typically is higher in fat. And limit your processed foods. I love that we're saying the same thing here. So I like to think if we just focused on eating fish, eating plant-based foods, your fruits, your vegetables, your whole grains, nuts, seeds, oils, that we would pretty much be lowering our risk for all the chronic diseases that we find in America. And what's interesting is if you look at other countries, based on the diets that they eat, we have different disease states. America is in a bubble of its own, and China is following right behind us because they're eating the same diet. So I liked this, so I took a picture of it and said, I'm gonna just throw this up there. Because this on the left is an ultra-processed way of eating versus a unprocessed way of eating. So instead of eggs from liquid, or your egg beaters, with pork sausage, honey buns, and orange juice, if you had a vegetable omelet, this one has spinach, onion, and tomatoes in it, with sweet potato hash browns, yum, with bananas and milk, then you would be having real food, right? Instead of your hot dog smothered with your ketchup and your mustard, and you're doing better by having baked chips, your blueberry yogurt, your cranberry juice drink that doesn't have 100% real juice in it. Instead, you had fish or cod with a baked potato, a salad with some vinaigrette, broccoli with olive oil and garlic. You'd be doing so much better. And for dinner, well, let's forget the steak, bean, cheese burrito with the salsa and the sour cream and the tortilla chips and the diet lemonade, because we're trying to do better with the diet lemonade. We have apples, grapes, salad, vinaigrette, black beans. Hopefully we've cooked the corn and it's not still frozen, avocado, and almonds. Do you get the idea? Here's another one. Honey Nut Cheerios, it helps lower your cholesterol. You should eat it because it's whole grains with milk and blueberry muffin and margarine. But I'm going to have my yogurt with my fruit and my, I can't read that, frozen strawberries, walnuts, and homemade granola. Yes, that might have some honey in it with a little bit of sugar. That's okay, though. I'm not going to have my ravioli anymore. I grew up eating that stuff, and I wouldn't touch it with a 10-foot pole nowadays. But I'm going to have a spinach salad with fresh fruit and vinaigrette. I'm going to have grapes for my dessert. And then the typical dinner. And I don't know why I'm going to drink chocolate milk and diet lemonade. Maybe I'm really thirsty and I like the sweetness of it all. But I'm going to have my beef roast with broccoli and oranges, rice pilaf, pecans, salad, vinaigrette, and sunflower seeds. Maybe I'll throw pumpkin seeds in there because that could be beneficial. So these are the top 3 eating patterns that we have found in the world of dietetics to be the most sound and to also benefit our heart and our health the most. So the Mediterranean diet, you've possibly heard of it. A lot of people have. Some people have even tried it. So ultimately, it's just a foundation of fruits and vegetables, herbs, nuts, beans, and whole grains. Meals are built around plant-based foods. We have moderate amounts of dairy, poultry, egg, and we throw fish in there fairly often. The second one in the middle there is the DASH diet. This DASH stands for Dietary Approaches to Stop Hypertension. So if somebody came to me and said, hey, I want to lower my blood pressure, it's creeping up there, or I just found out it's 200 over 100, and I go, yes, let's do something. The DASH diet is where we would go because it really enforces potassium-rich foods, which are fruits and vegetables, low-fat dairy, a little bit of meat, a little bit of fats, nuts, beans, legumes, a little bit of desserts. I have a rule with my kids, 1 sweet a day, and I try to keep that under 150 calories, maybe under 200 calories, just as a guideline. So that kind of follows that. It says, hey, you can have stuff in moderation, right, that's sweet. You also get a wild card, so if you wanted to have 2 servings of meat that day, you could. But ultimately, it is a very healthy way of eating. And it's mainly plant-based foods. And then the last one is the flexitarian diet. I hate the word diet. It's a 4-letter word. It's really a way of eating, or it's a eating lifestyle, or an eating pattern. And if you look at it as 85% of the time I eat this way, and then I have that smaller percentage of the time that I don't, because there's a birthday party or a holiday meal or what have you. So the flexitarian way of eating slowly reduces meat intake, which benefits the prostate. So we're putting in more vegetables in its place, and we're doing it slowly so that we're slowly getting healthier. So we're trying to maybe have 1 meal a day that's a vegetarian meal. Maybe I put beans in the place of meat, or maybe I have a veggie burger or something, that's a meat alternative. And then maybe I've gotten to the point where it's not just 1 vegetarian meal a day. Maybe I only have meat on the weekends. So we're being pretty flexible, but we're moving in the right direction. So just keep those eating patterns in mind and see if maybe something is attractive to you that maybe you could apply. Let's talk about some common myths. So he mentioned lycopene in tomatoes. So as a dietitian, I have always known lycopene, that is the one thing that you can consume in your diet on a regular basis to lower your risk for prostate cancer. And I tell this to guys all the time if that topic comes up. And I actually found through my research that there's a lot of weak evidence backing this up. So it really debunked my myth of what I've always known. Isn't that nice? I learned something through preparing for you guys. That doesn't mean that you can't have tomatoes, right? But just know that lycopene is beneficial. It maybe won't reduce your risk, but the best way to get lycopene is going to be in your concentrated form, like your ketchup. Not necessarily ketchup, but like your tomato sauce, your tomato paste, your tomato juice. You get higher doses because it's concentrated than you do from just tomatoes. So put a little bit of tomato here and there, have your sauce. Just don't put it on pizza and have pizza all the time because that's going to work against you, right? Green tea, already been mentioned. Great antioxidant benefits. Lowers inflammation inside the body, helps fight free radicals that lead to cancer, all cancers. Research actually shows for those with prostate cancer, if drinking green tea, maybe in small doses because of the caffeine, but if drinking it while you're going through treatment, there's more benefit than if you're trying to reduce your risk for cancer. I thought that was quite interesting. It also has been found to help reduce your risk for a stroke. So it's not that certain things are the only things that are going to reduce your risk in the foods that you eat and things that you drink. But they're not bad, right? Everything in moderation, and some things really do have a good bit of benefits. Yum. Anybody ever drink pomegranate juice? Yeah? How much do you drink when you drink it? We had like 5 people raise their hand. Anybody want to tell me roughly how much you drink? 8 ounces over here. This amount? 4 ounces. Do you do it daily? Okay. So the main producer of pomegranate juice is Palm Wonderful. You've probably seen their cute little bottles, in the refrigerated section of the grocery store. So they used to boast about their pilot study that measured PSA levels of men who had undergone surgery or treatment for prostate cancer. And in 2006, it seemed that the juice these men drank was helping, although there was no control group to actually compare it to. So then they turned around, they tried to publish another study with the control group, but they found no significant difference in the benefits between the group with the placebo and those taking the pomegranate liquid extract. In 2015, the Federal Trade Commission forced Palm Wonderful to halt other misleading claims like heart therapy and proven to fight for erectile health. Does that mean that you shouldn't drink Palm? No. That means that this company was pushing it and saying, hey, this is going to possibly lower your risk for certain diseases. So these claims, you have to be careful. You have to see if there's research or ask somebody who works within research-based health professions to find out, is this the real deal? Just like the grocery store supplement, was that really researched? Was that studied in a study where they found that it was helpful, or did they just post that claim? So in summary, don't always believe what the companies claim unless you can find a decent study that backs it up. Pomegranates are still wonderful. I actually did a research study on that while I was in school and found that the benefits, the antioxidant benefits that you get from pomegranate juice, You only need 1 ounce a day to get those benefits. So that bottle is gonna last you a good bit longer, and you have a little bit more money in your pocket. Because even if you had 2 ounces, think you're gonna double that effect, it doesn't. Because the research that we do have shows it only takes a dab to do ya, right? What about a multivitamin? A lot of people take multivitamins. This is from 2016 from the Center for Science and Public Interest. They are my favorite nonprofit that pushes a lot of nutrition guidelines in America. They're the reasons that we have nutrition labels. They're the reasons why calories are posted up in Panera when you eat there and other big restaurant chains. So they posted this about what your multivitamin should contain. If you have a phone, take a picture of it. Because if you're currently taking a multivitamin, you want to compare to this picture right here and make sure that yours stacks up with what's recommended. And the vitamin D, they actually did this in my health letter. They did it in like 2007. And then in 2016, that vitamin D number changed dramatically. And now even on our nutrition labels, we can see how much vitamin D in the new labels that are coming out, how much vitamin D is in the foods that we're consuming because we have so many deficiencies. So you can compare your multivitamin. If you're not taking a multivitamin, check with your doctor before you do and make sure if you're on any medications, it's not going to counteract anything that's in the multivitamin. Anytime you try any, just like he said, any herbal supplement, check with your doctor first. You don't want to mess something up because it's over the counter, right? So the list to the right is a summary from the Center for Science and Public Interest. And maybe your multivitamin is on the list, but if not, you might want to consider one of these. Not all of them were tested. We're not getting paid by any of these companies to promote their multivitamins, I promise. But if you want to make sure that you have one that fits this criteria, those are ones that they found did. And I look at a multivitamin like a health insurance. You're not going to get all the vitamins and minerals from the foods that you eat every single day that you need. You might in a 3 days' time, as long as you're eating a variety. So your multivitamin is kind of like a backup insurance. So in summary, aim to have a healthy eating lifestyle on a regular basis, 85% of the time, filled with lean meats, and the less meat, the lower your risk. Lots of plant-based foods, less processed foods. Hopefully you got some ideas from those pictures earlier. Eat more fish, fiber that comes from our fruits and vegetables and our whole grains. We're typically not getting enough fiber. Beans, nuts. Don't listen to supplement hypes. The FDA does not regulate any supplements. Nothing gets tested. There is a group called Consumer Labs. You have to pay a lot to be a member of it, but they actually test all of these supplements and they rank them. So if you are using a lot of supplements and you're like, it's worth, $100 for the yearly subscription, you can go to consumerlabs.com and actually pay that and see what they've tested, and they rank them based on, is what they say actually in this supplement? Because they test it all. So your daily choices speak volumes. And I like the saying, I really do. You are what you eat. Do you eat junk? Or do you eat healthy? And the more plants that you eat, the healthier you're eating and the healthier your body's going to be. And your weight reflects that too. And then one last thing that I like to say, sometimes it's kind of putting it into black and white, but I think of it this way. So when a plant is growing from the earth, it is filled with life. It's got photosynthesis in its leaves. It's creating energy. It's got nutrients. It's like a ray of sunshine, right? We pluck that from the earth and we place it into our bodies. When we have our meat, there is no life. Not saying don't you know, but just think about it, right? Put more life in so that you can have more life. I hope that you have learned something new today, just from my portion. I know you've learned tons new from everyone who's spoken today. And I am happy to take any questions in hopes that I can answer them.
Yes, Robbie, we'll get quite a few for you as well. If immunotherapy is under consideration as a treatment option for prostate issues in maintaining a healthy immune system, oh, I'm sorry, there's no period there, but I think it's supposed to be there. Is maintaining a healthy immune system on an ongoing basis a good preventive measure to avoid contracting prostate cancer?
Definitely.
Next question.
I mean,
GMO. Actually, somebody wonders, is this the cause of our urological problems?
so we don't have enough research on genetically modified foods because ultimately they've only been around for, 40 years, most of my life. And so there is a lot of belief that genetically modified foods could cause problems in the future, but we don't have any research to back that up. It is not going to work against you to choose organic because anything that's labeled organic, by definition, is not genetically modified. And so that is something that you can choose to place into your lifestyle. I will say, too, that there's the Environmental Working Group, which is ewg.org, that you can look into. And they actually have a lot of information about genetically modified foods, about pesticides on fruits and vegetables, so that you can be more educated in what you choose at the grocery store. They also touch on chemicals in lotions and shampoos and cleaning products that are there to protect your health so that you can choose healthier products.
Next question talks about soy protein. Is it good or bad for prostate health?
So there is not much research that talks about soy protein and prostate health, but I actually took a large CEU course on soy protein yesterday and the day before, and soy protein really gets a bad rap, but it's not all that bad. What you want to know is that it is a plant-based protein. It has all the amino acids to function as a meat protein. So if you eat just soybeans, or if you have soy that is in something that you're eating, you are getting a good quality protein. It's low in fat, it's high quality protein, and it can be a plant-based source of protein if you are going flexitarian or trying to go less meat. So soy protein has not been linked to lowering or increasing the risk for prostate cancer. There is only concern if you have a family member or if you were diagnosed with breast cancer that was estrogen positive, then it's recommended to not consume soy products because it mimics estrogen. That's the biggest research that's out there.
There's a question about supplements. You know, a lot of schools of thought sometimes dismiss that as basically just enriching urine because of absorption issues. What do you think about that?
I'm sorry, can you say that again?
Absorption issues with supplements. Some people argue that there's poor absorption of supplements and therefore you're pretty much just enriching your urine.
It really depends on the supplement that you're looking at. For example, in order to absorb calcium, you must have vitamin D. You know, so if you're just taking calcium, you don't have any vitamin D, well, then you'll have poor absorption. So it really just depends on what we're looking at. Ultimately, If you are taking an individual supplement, don't take it because Dr. Oz told you or your mother-in-law suggested that you take it. You need to know the specifics of why should I take this? Check with your doctor, because you might have poor absorption if you have certain medications that are taken at the same time. Or it might be that it increases the dose of whatever when you take it. So you just don't know.
And I think that is the whole list of questions I've received so far. Again, if we get some more later on, we can actually route them your way so you can be able to respond, and we can find a way to get back to those of us who are asking that. Well, thank you so much, Robbie, for your time.
Thank you.
We're doing very well on time, so we're glad at least we're getting all the lectures in, at least right on time. In the closing, we will invite our pastor, who is actually the host pastor, to come in and wrap it up. So this is the final segment of this particular session of the symposium. Pastor Christian Ronalds is right here. Welcome.
Thank you, Dr. Enos. Thank you very much to all our presenters. You guys did a phenomenal job, and I learned a lot. I learned a lot that I'm going to be taking to heart after these meetings. In fact, immediately after these meetings. I think I'm going to have to be transitioning. Where did Robbie go to? I'm going to be transitioning away from the SAD diet, standard American diet, to a healthier diet after that. So again, thanks for all that you've shared. And I hope that we didn't just learn a lot, because I know I learned a lot, but we're going to, take it to heart and apply it in our lives. I want to add too, just a reminder that everyone who's preceded me, they're health professionals. I am not a health professional. I'm a pastor, and I'll be sharing what I share is from the Word of God. So if you may, let's bow our heads together for prayer. Heavenly Father, as we bow in your presence, I pray, Lord, that you'll please be with me at this time. I pray that the words that are spoken here will come from you, and they will flow and they will touch and speak to every heart, every person who is in this building, but also all those who are joining us virtually online will be blessed. In Jesus' name, amen. Is that true or false? I mean, you know that's true. I mean, if we hear a squeak, one squeak in our truck, we've got it in the shop the next day. Isn't that right? The very next day, it's in the shop. We're looking at it. We're not mechanics, but we're under there helping the mechanic, and we're giving him advice as to what we think it is because, we heard it first. And we know what it sounds like. On the other hand, that same man will live with chronic pain for years. Years! As long as it's not stopping him from working. Do I have a witness? Nobody here knows what I'm talking about, and that's good, right? That's how men are. Anything that just remotely looks at like self-care, we don't want anything to do with it. And could it be because we have grown up hearing lies, certain lies, throughout our lives? For example, the first lie that men grow up hearing, and I grew up hearing this lie, is that men, we're invincible. Do I have a witness? We are invincible. I mean, we tend, just by our nature, by our being, to think that, we're Arnold Schwarzenegger. We're the Terminator. I mean, nothing can stop us. It's like, I broke my leg. I'll be back. And we're thinking, we're invincible. Nothing can ever stop us. No matter what we face, we're going to bounce back from it, and we'll make it through. The fact of the matter is, with the passage of time, we're going to wear out. We can't help it, and some of us wear out faster than others. But men, we're not invincible. We are going to wear out eventually. Perhaps one of my favorite characters in the Bible, and perhaps one of the greatest warriors in the Bible, was David, King David. You guys know King David, right? King David, only a boy named David. He slew Goliath with a sling and a stone. That same shepherd boy that I'm talking about. But as mighty as David was, David still fell victim to the ravages of time and the hardships of being a fugitive and, all the wars that he fought. David, he lived a hard life. And the Bible tells us in 1 Kings chapter 2, verse 10, it says, so David rested with his fathers and was buried in the city of David. So he died. We knew he was going to die. He died. Now, it's true that David gave his life in faithful service to God and God's kingdom. But the sad thing is this. This is the sad thing. In 2 Samuel chapter 5, verse 4, it tells us, David was 30 years old when he began to reign, and he reigned for 40 years. And after that, he died. How old was David when he died? 70 years. 30 years when he became king, reigned for 40 years, and that's it. He died 70 years. Now, added to that is the fact that as the Bible describes David's last days, weeks, months on earth, it says that at 70 years, he was old and advanced in years. In fact, he was so old that he couldn't even keep himself warm. They had to find an artificial source, which we will not discuss at this time, to keep David warm in the last days of his life. Now, at 70 years old, for a man in David's position, at that time in Bible history, being king, that was not old. And even for us today, we know for sure that, that was not old. But worse yet, for him to die in a feeble condition. You see, friends, David had a problem that is still common today to all of us men here, even the little ones. You guys know what that problem is, right? David was a workaholic. Do I have a witness? David was a workaholic. David threw everything. He threw his all into whatever he was doing at the moment, and he never took the long view. David lived by the motto, carpe diem, seize the day. And as a result, he wore out much earlier than he needed to. David should have been around much longer. If not just to serve as king, he could have been there as an advisor for his son, Solomon, when he took the throne. Have you ever wondered what would have happened, with Solomon if David had been around a little bit longer to give him advice? Maybe he may have avoided some of the mistakes that he made. Friends, workaholism may seem like a noble way to go, but it is not God's way. God's intention is for us to live a life of fulfillment, of full, abundant joy until he returns to take us home, and then we're going to get to experience eternity. Friends, the concept, that we're expendable, we're like Sylvester Stallone's Rambo, we go, mission accomplished, I'm dead, it doesn't matter, as long as I get the mission done. That is not God's way. That is not biblical. God wants us to take appropriate care, men, of ourselves. And this includes getting adequate rest, recreation, vacation, eating properly, exercise, and just going to work doesn't just qualify as exercise. Additional exercise on top of that, cardiovascular exercise, aerobic exercise. He wants us to do all of those things so that we can live a well-rounded life, and even worshiping God and going to church. They all contribute to health and wellness. In fact, when it's talking about vacations, even Jesus recommended vacations. We talked about this earlier in our sermon. Mark chapter 6, 31 and 32, it says, then, because so many people were coming and going that they did not even have a chance to eat, he said to them, come with me by yourselves to a quiet place and get some rest. So they went away by themselves in a boat to a solitary place. Guys, Workaholism, being Rambo, even if it's Rambo for Jesus, it's not God's way. That was never his intention. Jesus understood the importance of rest and recreation. In fact, if we don't give ourselves time to rest and recuperate, not only will we shorten our lives and our years of service to our families, to God, to our employer, the quality of our service is going to be following the law of diminishing returns. We're going to be giving less and less. We're going to be working harder and harder, but getting less and less results of a lower quality because we're not taking care of ourselves. We're not working smarter. We're trying to work harder, but we're not taking care of ourselves. And also, another thing is this. You're going to lose your competitive edge because you're going to find if you don't care for yourself and you don't care for this great organ, your creativity will suffer drastically. And if you're not creative in this day and age, you're going to get blown away by the younger generation that's coming up. So another great example of self-care, and this one was really, really eye-opening for me. I looked at a group of people in the Bible who are known for their longevity, known for their long life. And I was surprised when I looked at that and I looked a little bit more in depth. Does anyone make a guess about what that people group is that were known for their long life? Raise your hand if you think you know who they might be. Anyone? I hear the Israelites in the wilderness. That's a really good one. Yep. But there's another group in Scripture that generally are referred to, in many contexts, they were long-lived. Anyone else? Well, it's very simple. I'll tell you who it is. It's the priests. The priesthood. Generally, they were very long-lived. What is it that set them apart? What was it about the priests, that I had to look into this, and then I discovered something in 1 Chronicles chapter 24. And here we see that the king who was the king at the time, and this was 1,000 years, BC. I'm not going to tell you who the king is just yet because of the irony of it all. The king at the time set up the priests in 24 divisions. 24 divisions based on their families. And this is how it worked. Of these 24 divisions, each priest would come to the temple twice per year to serve in the temple for 1 week. So he'd come for 1 week and he'd serve, and then his next course would be approximately 6 months later, serving in the temple for 1 year. Besides that, there were 4 major Jewish feast festivals when all the priests in Israel would come and they would stay for the entire festivals, which could run, between a week and a month. So when you look at that work schedule, hey, can I get that kind of work schedule, guys? 2 weeks a year, plus somebody back there shaking his head, no way, no way. And then look at that work schedule. The priests they were definitely not, overworked or workaholics when it came to their ministry to the temple. And they were known as one of the longest living groups in Scripture. And you want to know the irony of it all? You know who set that system up? David did. David, the workaholic king who worked himself to death, set up a system for the priests that helped them to be one of the longest living groups in the Bible. Guys, we need to take care. We need to take care of our health. Zechariah is a prime example. We read about him in Luke chapter 1, verse 5 to 7. It says, in the time of Herod, king of Judea, there was a priest named Zechariah who belonged to the priestly division of Abijah. His wife Elizabeth was also a descendant of Aaron. Both of them were upright in the sight of God, observing the Lord's commandments and regulations blamelessly. But they had no children because Elizabeth was barren and they were both well along in years. Well, we know the story. Shortly thereafter, God blessed them with a child. But they were well along in years and still serving and giving good service to the Lord. Friends, guys, you got to just crank it down a bit when it comes to that workaholism. Take time to care for yourself. Take time to be there for and with your family and to nurture yourself and minister to yourself and also to get the care that you need from the health professionals. Now, so men, we're not invincible. If we want to be around for a ripe old age, we need, and also to care for our beautiful wives, and to support and encourage our kids and give them counsel, we need to stop living to work and we need to start working to live. Take time for recreation, vacation, so we can recuperate our strength. Now, here's another lie that some men believe. And that's that we are indestructible, like Superman. In fact, every man, deep down in his heart, he knows that he's Clark Kent. And hidden inside of that Clark Kent is a Superman. We all know that we're Superman, and we can draw on that Superman when we need him. Yes, I may be mild-mannered, but inside truly am Superman. I'm indestructible. And even the passage of time has no effect on me. Maybe that's why men are so self-confident. I mean, you just check it out. Ladies, I'm not knocking you, but a lot of ladies, from the time they turn 40 years old and they see a mirror, what do? Mirror, no! They run and they hide from the mirror. Guys are like 50 and 60 years old, and they see a mirror and it's like, yeah, still got it. Still got it. I mean, we're walking in the mall, and we're walking by the stores, and there's a glass pane window there, and you can just barely see a reflection in it, and you're like, yep, 79, and I'm still rotten my stuff. Yeah, we think we're indestructible. We have that, that we'll always be around. The passage of time will have no effect on us. But the fact is, friends, we're not men, we're not indestructible. And I think that's one of the reasons why God has given us wives, to keep us humble, to bring us down, let us know that you're not made of steel. You're just like I am, to keep us humble that way. We're not indestructible, and the passage of time and bad choices and harsh living will wear us down. And the harsher it is, the faster we will wear down. The strength of our youth will not last forever, but it doesn't have to be that way. There are some things that we can do to extend our strength and our life as long as possible. Things that we heard about, from our dietitian and our pharmacist and our doctors, eating a healthy diet, getting regular exercise, aerobic and anaerobic, strengthen the heart, strengthen the muscles, increase the bone density, or at least maintain it so it doesn't whittle away. We need to work on our relationships also, because a healthy social context is good for our health also. We need to remember that guess what? That truck is going to last 20 years, but you were designed to last 70, 80 years. We need to get routine checkups also. Whether we like to or not, at least once a year, we need to be in there seeing that physician and letting them run their tests so that we can identify problems before they occur. But there's one thing I haven't touched yet, and this is the most important. And that is, I'm a pastor, so I believe this with all my heart. I'm not just saying it because I'm a pastor. I've seen it in my own experience and others' experience also. We need to take time for our relationship with God. Oh, got an amen for that. We need to take time for our relationship with God. There was a man in the Bible, and he's one of my heroes. I like this guy a lot. His name was Caleb. Caleb was one of the 12 spies that went to spy out the land of Canaan when the children of Israel were in the wilderness and getting ready to cross over. You know the song, 12 men went to spy in Canaan, 10 were bad and 2 were good. What is this? You know the song. Well, Caleb was one of those 12 spies. Caleb and Joshua, the 2 that came back, they gave a good report, and they said, listen, we saw a land that's flowing with milk and honey. There were clusters of fruit that were so large that we needed 2 people to carry them on a pole. This is an amazing place. And they said, we need to go take it. The other 10 said, it's amazing, but the people who live there, they have huge cities with stone walls, and they're huge people. They're giants. There's no way we can conquer them. We're like grasshoppers in their sight. But Caleb, Numbers chapter 13, verse 30, the Bible says that Caleb silenced the people. He said, be quiet. He silenced the people before Moses and said, we should go and take possession of the land, for we can certainly do it. But we know the rest of the story. The 10 outweighed the 2. The people believed the 10, and they ended up wandering in the wilderness for the next 40 years. In fact, Joshua and Caleb were the only 2 who lived through those 40 years and made it into the promised land. Well, fast forward now, not 40, but 45 years. 45 years after this incident happened, we read that something very interesting occurred. We read about it in Joshua chapter 14. I'm going to read the scripture for you. It's a little long, but bear with me because the power comes from the Word. The impact comes from the Word. Joshua 16, and by the way, Joshua and Caleb. Joshua ends up being in charge of the children of Israel, and Caleb is, one of the, his, not quite his assistants, but a leader in Israel too. Now the men of Judah approached Joshua at Gilgal, and Caleb said to him, you know what the Lord said to Moses, the man of God at Kadesh Barnea, about you and me. I was 40 years old when Moses, the servant of the Lord, sent me from Kadesh Barnea to explore the land. And I brought back a report according to my convictions. But my brothers who went up with me made the hearts of the people melt with fear. I, however, followed the Lord my God wholeheartedly. Verse 9. So on that day Moses swore to me, the land on which your feet have walked will be your inheritance, and that of your children forever, because you have followed the Lord my God wholeheartedly. Now then, just as the Lord has promised, he has kept me alive 45 years since the time he said this to Moses, while Israel moved about in the desert. So here I am today, 85 years old. What's 40 plus 45? 85. How old was Caleb? 85 years old. 85 years old. And he says, so here I am today, 85 years old. And verse 11, he says, I am still as strong today as the day Moses sent me out. I am just as vigorous to go out to battle now as I was then. And you know what he said to Joshua? There's a mountain there with giants, and no one can conquer them. Give it to me. And he went and he conquered the giants at 85 years old. Hey man, can you imagine being as strong at 85 years old as you were at 40 years old? Wouldn't that be awesome? How many of you here would like to be strong at 85 years old, as strong as you are when you were 40 years old? Raise your hand. I see some hands going up in the back. I'm raising 2 hands, man. That's me. I want to be like Caleb. If I hit 85 and the Lord doesn't come, I want to be as strong as I was, when I was 40. And that's Caleb's story. But did you catch the key ingredients of this account? There's a key ingredient, and it's found in verse 9. It says, so on that day Moses swore to me, the land on which your feet have walked will be your inheritance, and that of your children forever, because, conditional, because you have followed the Lord my God wholeheartedly. So men, I'm challenging you today. Yes, eat right. Yes, exercise. Yes, boost your immune system. Yes, nurture your families. Nurture yourself. Get those checkups once a year. And if you're getting older, do 2, twice a year, or more. Do all those things. But the most important thing is to fear and serve the Lord with all your heart. Maybe we'll have a few more Calebs in our midst.
To our online audience that have stuck with us through the whole session, and more importantly, to those of us who sacrifice time to put together the content and to actually be here physically to be able to present the respective areas of their specialty. We cannot thank you all enough. And we want to congratulate this facility, this church, for being nominated, of course, declared to be a center for men's health awareness, which basically gives us a task to be able to continue this year after year after year. And therefore, those of us who have come to share with us, again, like I said earlier on, we're going to partner with you to be able to expand this into a huge thing so we can be able to work towards the health of our men. I'm sure the ladies too in their department perhaps might still be turning to you down the road to address some of these issues on the side of the female gender. Edwin, did you want to say something on behalf of the department? Okay. You want to come up here because we're live? Okay. And Elder Layton, if you want to come and start with us here so you can give us a closing prayer, sir.
Just a brief comment, just to say to our presenters, incredible, just incredible. We are so blessed, and we are most informed. Just want you to know we most certainly appreciate you coming and sharing your knowledge with us. Thank you so much. Thank you so much.
I know that we've all been sitting for quite a while, so we'll all stand up for our closing prayer. Appreciate you folks hanging in there with us for this afternoon and hearing these incredible, informative presentations. I know I've learned a lot, and like Ina said, going forward, we'll be looking for other types of topics to be discussing so that as we continue forward, we'll be as healthy as possible. Let us pray. Father God, we thank you for this opportunity that we could come together and learn all these incredible things from very learned instructors and those who have very high degrees. So Lord, we thank you for the wisdom that you've imparted on these individuals and what they can do for the community, Father. And we just ask a very special blessing upon each one that has come apart today and has been part of this process, Lord. Use them in a mighty way to touch the lives of individuals in our communities so that overall the Birmingham area has a much better quality of health because these individuals have dedicated their lives to the betterment of our society and the health of our society. So Lord, we just ask a very special blessing as we part from this place and this next week, Lord. Help us always look for ways to allow you to influence our lives in a greater way each day of our life is our prayer in Jesus' name and for his sake. Amen. Thank you.